very good morning, everyone. It gives me great pleasure to welcome you all once again to Day 2 of the Mid-Year Conference of Indian Psychiatric Society, Rajasthan chapter, Mid-Psychon 2025. After a truly enriching and intellectually stimulating first day, we are excited to continue our journey today under the central theme, Shifting Paradigms, Gender-Sensitive Psychiatry for a Changing World. Yesterday's sessions sparked insightful conversations and highlighted the need for continued dialogue and action towards inclusive, equitable, and responsive mental health care. Today, we delve even deeper into emerging perspectives, physical framework, and interdisciplinary approaches that can redefine psychiatric practice through a gender-sensitive lens. With another excellent lineup of speakers, workshop, paper and poster presentations, we look forward to dynamic exchange that will not only broaden our understanding but also inspire change in clinical practice and policy. We hope you make the most of today's sessions, engage, question, reflect, and connect. Let this day be one of continued collaboration, learning, and shared vision. Thank you for your active participation and presence. Let's make Day 2 of Mid-Psychon 2025 as impactful and memorable as the first. We now begin with the paper presentation sessions, and for the same, I would like to invite our esteemed judges, Dr. Jitendra Jindal sir, Dr. Rup Sidana sir, and Dr. Vinod Daria sir. We are pleased to welcome all the dignitaries, judges, and participants to the paper presentation session. This segment offers a platform for students, researchers, and academicians to showcase their scholarly work, share innovative ideas, and engage in academic dialogue. Presenters are encouraged to focus on clarity, originality, and relevance of their research to the theme of the event. Before we proceed, let me point out some basic rules for the presentation. Each presenter will be allotted 6 minutes to audience and judges. Adherence to the time limit is expected to ensure smooth flow of the event. We look forward to an engaging session of intellectual exchange and meaningful conversations. For the same, we would like to now call upon our first speaker, Dr. Nidhi from R&T Medical College, Jaipur.
Before that, I would like to inform you all that we have some rules for the presentations. You have to finish your presentation within 6 minutes, and for the discussion, you have 2 minutes. Being a judge, we request all of you, audience, you can ask the questions. Just ask the question. Need not to comment over the presentation, this is best presentation and like any other kind of comment. Avoid to comment over there. You can ask. Simply ask the question.
Dr. Nidhi from R&T Medical College, and the topic for my paper today is a study to assess role of personality traits and stressful life events in acute transient psychotic disorder patients. Stress can be defined as a process where individuals perceive and respond to events that are appraised as overwhelming or threatening to their well-being. Stressful events frequently provoke psychiatric disorders. Such events can provoke emotional reactions that are distressing. However, a proportion of patients with acute psychotic disorders arise without any stress. The term personality refers to those enduring qualities of an individual that are shown in their ways of behaving in a wide variety of circumstances. So, gaining an understanding of and familiarity with patient personality is important, as different personalities predispose to some psychiatric disorders that may color the presentation. Personality can predispose to psychiatric disorder by modifying an individual's response to any stressful event. Hence, it is important to identify common stressful and personality traits of a person that make a person prone to development of acute transient psychotic disorder, so that future episodes of illness can be prevented or modified. Aim to assess role of personality traits and stressful life events in ATPD patients. Objectives are to assess role of stressful life event in ATPD patients, to assess role of personality traits in ATPD patients, and to find the relation between stressful life event and the personality traits. So it was a cross-sectional prospective observational study. Patients presenting to the department diagnosed for the first time as ATPD were included in this study. So total number of patients evaluated were 246, and and out of them 93 did not fulfill the inclusion criteria. So we had 153 who were fulfilling the inclusion criteria. And inclusion criteria included patient willing to give informed consent, age between 18 to 60 years, patient diagnosed with ATPD according to the ICD-10 criteria by the psychiatrists. And out of those 153, 41 were excluded on the basis of exclusion criteria, and at the end we had a sample of 112 participants. Exclusion criteria included patients with history of significant substance abuse or dependence except tobacco, and the patients who were medically unstable. Assessment tools used were self-designed performer, presumptive stressful life event scale which included 51 events, brief psychiatric rating scales which included 18 items, revised Einstein personality questionnaire which had 24 items. It has 4 subscales including neuroticism, extraversion, psychoticism and life scale. The data obtained was entered into MS Excel for Windows and analyzed using IBM SPSS version 23. Categorical variables were expressed as percentages and continuous variables were expressed as mean. P-value less than 0.05 was considered as statistically significant. Now coming on to the results. In our study, there is no significant difference in the percentage among the male and the female participants. Out of the 112 patients, majority of the patients, that is 51%, were from the age group 18 to 30 years of age, and most of the participants, 75%, belong to the rural background. 58% patient cases were married, and out of them 35% were single and rest were either separated or divorced. And according to the results, stressor had significant role in 67% of the cases, and among them 47% of the cases had single stressor, and 20% of the cases had only 47% of the cases had single stressor, and 20% of the cases have more than one stressor. As shown in the graph, so most common stressor that was found in a study was the family conflict, followed that was 32 out of the total 112, followed by the marital conflicts, major personal illness, and the financial loss. Out of the total participants, 82% of the patients followed up, and 18% of the patients were dropped out after the first visit. So among the follow-up cases, 29% had extroversion personality traits, 24% had neuroticism, and very little, that is 4%, had psychotism personality traits. Out of the total participants, 67% of the neuroticism and 69% of the total extroversion had association with stressor. In contrast, psychotism personality traits, 70% of the participants had no stressor. And the patient with family conflict stressor, out of them, total 32, and majority of the patient had belonged to the extroversion personality traits, and out of them, financial loss and trouble at work was mainly seen in neuroticism personality traits, and major personal illness was also most commonly associated with the extroversion personality traits in our study. Discussion. The study findings revealed that out of the total participants of the age group, 13 to 18 years is found more among the total participants. Our study was supported by a study conducted by Oyumi S.N. et al., Mehta S. et al., and Sajid S.D. et al., and ICMS study also had frequently reported that an earlier age of onset of this illness. In the study, 75% patients were diagnosed more among the rural population, and these findings also align with the study conducted by Murlidharan S. et al. The study highlights that stressor had significant role in each aspect, with most common stressor being family conflict, followed by marital conflict, which was in contrast to the study conducted by S. Malhotra et al., where major stressors were physiological stressors like fever and childbirth. Another study conducted by L. et al. Revealed that major stressor associated was So this study underscored the critical importance of addressing stressors and personality traits in ATPD patients. The major stressor found was the family conflict, and most of the patients had stressor as the precipitating factor. And in this assessment of personality trait, both extroversion and neuroticism were associated with some kind of stressor. However, psychotism personality trait had no association or very less association with this stressor. Thus, we as clinicians must consider the illness and certain personality traits that make person vulnerable to development of the illness, and psychoeducate the patient as well as the caregiver regarding it so that the future episodes of illness can be prevented. Limitations. It was modest sample size and most of the patient, few of the patient had to drop out of the first visit. Thank you.
Thank you, Dr. Niti. If there are any questions, I have one question. Out of the stressors, you have mentioned family conflict, financial loss, and others. Grief or death from in the family or any loved one, was that not considered as stressor in the study?
Okay. It was considered as a stressor in the study, definitely. However, that I mentioned stressor that I mentioned in the paper, those were the most common that were found. They were less common out of the total 51 items that were in the scale. So out of them, in our study, that stressor was less common as compared to the stressor that was the family conflict.
It was not even mentioned in the whole graph. See, death of a family member or those.
Anyone else want to ask? See, at what time you have assessed this patient? At what time? You applied these scales?
So, when patient was admitted or either patient visited the OPD, during that time, assess design performance and including basic design, and at that time, from the caregiver, from the attenders and PSS LES scale was applied.
From the attendant. Attendant has been filled this PSLE?
We took the information from the caregiver because patient had psychotic symptoms. So, on the basis of the observation that we made and along with the information that we could get from the patient's caregiver or the accompaniment, including both the things, PSS LE was applied on when the patient visited.
So, at the time, first visit, you have applied the PSLE and what time you have evaluated for this personality traits?
So, when the patient's BPRS score was less than 30. So, when patient had minimal psychotic symptoms below 30, when the patient on the either it was on the first follow-up visit or on the second follow-up visit, when
it means you have evaluated this patient for 2 times. First, for at time when patient presented first visit for the stressful life event, and second time after follow-up, first follow-up or second follow-up when the BPRS scores is down,
yes.
evaluate for the personality traits.
Yes.
But it would be better if you can evaluate for the stressful life events after the in the remission phase of ADP. Thank you. Next one, Dr. Deepa Jindal. Please be ready.
A very good morning to everyone. Myself, Deepa Jindal from RNT Medical College. Today's my topic of paper presentation is a study to assess various factors responsible for relapse and stress coping behavior used by the alcohol and opium use disorder patients. Introduction. Drug addiction is a chronically relapsing disorder characterized by compulsive use of one or more drug of abuse, the inability to control drug intake, and continued drug use despite its associated negative consequences. Relapse is a complex and dynamic phenomena that seems to be determined by psychological, biological, and social factors and an interaction among these factors. When the individual are exposed to drug-related stimuli, the behavioral effects of the brain changes may be displayed in the recurrent relapses and intense drug craving. Self-efficacy is the perceived capability of the person to be able to resist the substance. It is affected by numerous cognitive processes and is mainly influenced by the experienced substance use in coping to a high-risk situation. Stress can be termed as a mental pressure which is responsible for an individual to change behavior. Stress encourages the use of drug and decreases the motivation to quit drug use. People often consume alcohol as a coping response to stress An adequate understanding of all these factors would help in harm reduction strategies. Aim: to assess various factors responsible for relapse and stress coping behavior used by alcohol and opium use disorder patients. Objective: to assess various relapse factors to assess the stress coping behavior. Methodology: it was a cross-sectional descriptive study. A patient of opium or alcohol use disorder attending psychiatric department fulfilling inclusion and exclusion criteria. Plan was approved by Institute Ethics Committee. It was a constitutive sampling. Inclusion criteria was patient who had given informed consent, patient of age group 18 to 60 years, patient relapsed after 3 months of abstinence from alcohol or opium use. Exclusion criteria was patient not able to read and understand Hindi or English language, patient having any physical or psychiatric disorder affecting ability to recall or report the required information. Number of patients recruited for opioid relapse was 254. Further patient evaluated for assessment was 226, and on the basis of criteria, patient excluded was 48, and finally we had opioid use relapse sample was 178. Number of patients recruited for alcohol relapse was 159. Patient further evaluated for assessment was 124. After putting exclusion criteria, patient excluded was 52, and we had sample of alcohol use relapse was 72. Assessment tool was self-designed pro forma, relapse precedent inventory Hindi containing 25 items, stress coping behavior scale containing 28 items. Statistical analysis, data was entered into Microsoft Excel, version 23 was used, p-value less than 0.05 was considered statistically significant. Results, our study involved 250 patients with majority of patients initiated substance use at age less than 20 years, and motivator for initiation of substance use reported by maximum patients were friends followed by family members. Majority of the patients reported first use substance as alcohol followed by the cannabis and then opium. Alcohol as first use substance was significantly higher in both alcohol relapse group and opioid relapse group. Pattern of initial substance use in majority of the patient was occasional followed by regular and then heavy. This chart showing majority of the patients in both alcohol and opioid relapse within 6 months. And in second chart we can see in opioid relapse group, majority of the patient had single previous relapse, and in alcohol most of the patient had 4 to 5 or more than 5 previous relapse. In the first chart, most of the patients had taken one time previous treatment for addiction followed by 2 to 3 times. In second chart, majority of the patient in opioid relapse group used inhalational route for substance use. Majority of the patient in our study had severe substance use disorder followed by moderate, and least patient with mild substance use in both alcohol and opioid. In our study, both total RPA score as well as negative mood state score was significantly higher in opioid relapse group as compared to alcohol relapse group, while no significant difference in alcohol and opioid relapse group with respect to positive mood state score and decreased cognitive vigilance. In our study, maladaptive coping score in opioid relapse group was significantly higher than in alcohol relapse group, while no significant difference in alcohol and opioid relapse group with respect to adaptive coping score. Discussion, in our study, age at initiation of substance use was young age, less than 20 years, which was supported by Beto SK et al., Suresh Kumar et al., Kadam et al., Rajesh Kumar et al. Our study finding revealed that maximum patient had single previous relapse episode followed by 2 to 3 previous relapse. Single previous relapse was significantly more in patients with opioid relapse group, whereas 4 to 5 or more than 5 were significantly more in alcohol relapse group. These aligns with the study conducted by Kadam et al., who observed greater number of relapse in alcohol. In contrast, another study conducted by Rajesh Kumar et al. Showed greater number of previous relapse in opioid group than in alcohol. Majority of the patient had less than 6 months of maximum duration of previous abstinence followed by 6 to 12 months. Maximum duration of previous abstinence less than 6 months was significantly higher in opioid relapse group, while in alcohol, maximum duration of previous abstinence 6 to 24 months was significantly higher than in opioid relapse group. This finding suggests that intensive initial care is required for opioid relapse group and long-term follow-up is required for alcohol relapse group. In our study, mean value of maximum duration of previous abstinence in months for patient in alcohol was 9.85 plus minus 8.65 and opioid group 8.69 plus minus 13. Conclusion: majority of the patients in our study initiated substance use at age less than 20 years, motivated by friends, used alcohol as first substance. Initially, pattern of use was occasional. Relapse precipitant inventory score total. Negative host state score was significantly higher in opioid relapse group. Mean score of maladaptive scoring, coping score was significantly higher in opioid relapse group. Our finding indicate that individuals with opioid relapse may benefit from intensive initial care to address the acute risk associated with relapse. In contrast, those with alcohol relapse may require long-term follow-up and monitoring to mitigate the risk of sustained relapse. These results highlight the importance of tailoring treatment approaches to the specific need of each substance use disorder group. Thank you.
Thank you. Are there any questions from the audience? Any questions from the audience?
Have you used any scales to assess the severity of the substance use?
So we just put the criteria of ICD-10.
But
It's like DSM-5 criteria.
sample size calculation. Have you gone through the sample size calculation before you conduct the study?
Yes, sir.
Sample size calculation, do you know?
Yes, sir. There is formula for sample size.
नहीं आपने किया था.
Yes, sir.
So what was the sample size for both the groups?
250 was total patients were.
नहीं वो तो आपने consecutively ले लिया आपने OPD में आया. But what was the sample size? Calculation से क्या आया था?
Sir, around 450. Thank you.
I have a question. When you started the study, what is the practical implication of your findings? Whatever findings you get in practical, what are the practical implications for patients?
लाइक ओपियोइड रिलैप्स ग्रुप वाले पेशेंट्स अगर हमारे पास आते हैं तो हम उनके फैमिली मेम्बर्स को एजुकेट कर सकते हैं कि लेस देन 6 मंथ्स में इनको ज़्यादा चांसेस है कि ये रिलैप्स कर जाएंगे, तो उनको हम मोटिवेट कर सकते हैं फ्रीक्वेंट फॉलोअप के लिए. उनको कभी भी मतलब पेशेंट को ऐसा लगता है कि बॉडी को है तो फैमिली मेम्बर्स को एजुकेट साइको एजुकेट कर सकते हैं. कभी भी ऐसा हो तो आप इनको हॉस्पिटल मतलब लेके आ जाएं ताकि वो उस टाइम पर रिलैप्स ना.
Thank you. Next is Dr. Komal Makwana.
Good morning, judges. Good morning, all of you. Today, my topic of paper presentation is a cross-sectional descriptive study to determine the different factors in relapse of the bipolar affective disorder. Introduction. Bipolar affective disorder is a complex, severe, multifactorial mood disorder. BPD is an episodic illness in which the episode of the depression, mania, mixed hypomania occur with the inter-episodic period of the remission. The current prevalence of the BPD in India is 0.6% for both the male and the female. It has been identified by the World Health Organization as the sixth cause of the air loss because of the disability in the young adult. The incidence in both the gender is nearly equal. The relapse represents a return of the symptoms satisfying the full criteria for an episode that occurred during the period of the remission but before the recovery. The word relapse, recurrence and the episodes are usually interchangeably in the literature on the bipolar disorder. The relapse and recurrence will be used synonymously for the purpose of the study. The frequent relapse in the BPD leads to the functional impairment and impairment in the quality of the life. The factors like the expressed emotion, stressful life event, compliance to the treatment have an impact on the relapse of the BPD. So the analysis of this factor and the deeper understanding of the relapsing nature of the BPD will be beneficial in developing the effective guidelines and strategies aimed at the reducing the number of the relapse and recurrence. Aim to assess the different factor in the relapse of the BPD. Objective to assess the type of the various stressful life event in the relapse of the BPD. To assess the clinical factor in the relapse of the BPD. It's a cross-sectional descriptive study. All the relapsed bipolar disorder patient aged between 15 to 16 years admitted or consulted in psychiatric ward and OPD. The plan for the study was approved by Institutional Committee. Study was completed within the duration of the 1 year. It was a purposive sampling Inclusion criteria include the participant willing to give the informed consent, age between 15 to 60 years, diagnosed bipolar disorder according to ICD-10, all the relapsed cases of the BPAD present in the psychiatric department. The exclusion criteria include the comorbid physical illness and the active surgical condition, not able to read and understand the Hindi and English language. The number of the patient evaluated for the assessment was the 390. Out of 390, 254 patients fulfilling the inclusion criteria, and after excluding the 74, the final sample was obtained 180. Assessment tool, semi-structure performer, level of the expressed emotion, 60 items involved, clinician rating scales, 7 items involved, presumptive stressful life event, 51 items. The data was entered into a Microsoft Excel for the Windows and analyzed using the SPS version 23. Categorically variable are expressed as percentage continuous variable were expressed as a plus minus standard deviation. P-value less than 0.05 was considered statistically significant. Results. In our study, the male participants were the 61.1% and female were found to be 38.9%. The majority of the participant rate is 39.4% belong to the age group 31 to 45 years, followed by the equal distribution of the age group belong to the 46 to 60 years, that is 30.6%, and the age group between 15 to 30 years, that is 30%. The majority, that is 86.1%, were from the rural background. Majority of them were the married, that is 80%, and were from the nuclear family, that is 79%. Among the 180 BPAD patients, in which the majority, 86.7% of the patients were in the manic phase and 13.3% were in the depressive phase. This is the graphical representation type and distribution of the stressful life event. We can see the out of 17.8% of the family have the most common family conflict is the main stressor, and which is followed by the death of the close one, financial loss and property damage. This graph shows the association between the number of the relapse and the expressed emotion. We can see the high expressed emotion patient have a higher number of the relapse. This is the graphical representation association between the number of relapse and the medication adherence. We can see in the clinical rating scores, 1 shows the higher number of the relapse and the 7 shows the lower number of the relapse. Discussion. In our study, the majority of the patients who belong to the age group of the 31 to 45 years. The majority were the married, belong to the nuclear family and were from the rural background. This finding of the socio-demographic profile aligned with the study conducted by the S. Karthik et al. Among the total sample 180 of the relapsed patient, the stressful life event were present in the 146, that is 81.11% of the patient, and absent in 34, that is 18.89%. The study finding highlighting the significant role of the psychosocial stressor in the relapse of the BPAD. In our study, the family conflict was the most common among the stressful life event, followed by the death of the close one, property damage, and the financial loss. This finding aligned with the study conducted by the Sam et al., who also determined the family conflict as the most common stressor. It was observed that the majority of the patients, that is 62%, have a higher number of the relapses when exposed to the high expressed emotion. Our finding was supported by the study conducted by the McLeod et al., which found that the high expressed emotion significantly increased the risk of relapse, that is 5 to 9 times higher in the BPAD patient. Conclusion. In our study, most frequent reports stressor for the relapse in the bipolar disorder were family conflict and the financial related problem. We found the highest score on the level of the expressed emotion in our study. The medication non-adherence were the significant factor for the relapse in the bipolar disorder. Limitations. The study was conducted in the tertiary care hospital, so the result obtained could not be generalized to the community settings. Our study was a cross-sectional study designed for the better results. Prospective study can be planned. We study only the limited number of the variables associated with the relapse in the bipolar disorder. Other factors like the personality profile and the cognitive factor can be included in the future study. The sample was small in number and the large sample size can be taken. Thank you.
Thank you, Dr. Komal. Any questions?
Madam, you can ask the questions.
My question is, one, what is the difference between relapse and recurrence?
सर रिलैप्स में तो रिकवरी होने से पहले अगर फिर से सिम्टम्स आ जाते हैं तो वो रिलैप्स माना जाएगा और रिकरेंस में कम्प्लीटली रिकवरी हो जाती है पेशेंट की. अगर उसके बाद अगर सिम्टम्स आने लग जाए कम्प्लीट रिकवरी के बाद तो वो रिकरेंस.
How did you decide whether the cases that you have taken are relapse or recurrence? Inclusion criteria.
According to the ICD-10.
Any relationship with substance abuse in your study? Did you consider it as a factor?
No sir, any substance.
Four main points. First, at what time you have evaluated these patients for PSLE?
सर जो साइकेट्रिक वार्ड में जैसे जो एडमिटेड हैं और ओपीडी बेसिस पे जो पेशेंट आते हैं तो उस टाइम.
In the acute phase, you have evaluated for PSLE. PSLE is scale to self-administer. So it would be not good to administer at time of acute manic phase. Have you included both the patients, manic or depression, or the only mania patient?
Both the mania and depressive.
And in the inclusion estimate, you have not mentioned that you have ruled out the other comorbid psychiatric disorder. If patient has schizoaffective disorder, patient is substance use and BPAD, patient have any other psychiatric disorder, what happened with these patients? Have you included in the study with comorbid psych? Then you have not been mentioned in the study. Exclusion criteria you have to be mentioned. Thank you.
Next, Dr. Tanay Agarwal.
Good morning, respected judges and everyone present here. Today's topic for my presentation is assessment of sleep quality among medical students, correlation with socio-demographic and clinical factors, a cross-sectional study. Sleep quality is essential for mental and physical health, but stress, lifestyle changes and technology use are causing global deterioration in sleep quality. Around 50% of adults globally suffer from sleep disorders, with 13% experiencing severe conditions. In India, about 20% of healthy individuals aged 16 to 55 struggle with maintaining regular sleep patterns. Medical students face high stress due to long study hours, academic pressure, and frequent exams, leading them to deprioritize sleep. Studies report that 30% of medical students have poor sleep quality, 40% experience excessive daytime sleepiness, and 33% show symptoms of insomnia. The aim of the study is to assess the quality of sleep in undergraduate medical students, where primary objective is to determine the sleep quality of undergraduate medical students, and the secondary one is to correlate sleep quality with socio-demographic and clinical variables. Methodology: a cross-sectional was conducted on undergraduate medical students in Ananta Institute of Medical Sciences. The sample size taken was 360. Study duration was from April to May 2025. Undergraduate medical students of at least 18 years of age or above who gave consent were included, while participants having any diagnosed psychiatric illness or serious diagnosed comorbid medical illness were excluded. Sample selection procedure: with prior permission from the institutional authorities, the students were approached in their respective classrooms. They were provided with a brief explanation regarding the purpose of the study, the voluntary nature of the participation, and the confidentiality of their responses. Data was collected using a self-designed pro forma on demographic details of the participants and the clinical variables, and a PSQS scale, a 19-item psychometric instrument used to assess the participants' sleep quality. It was performed with the help of software SPS25. Now coming to the results, the table shows the correlation of socio-demographic profile with the sleep quality. In this, the table shows the domicile significantly affects the sleep quality, with rural residents having better sleep quality compared to the urban and semi-urban residents. This is the bar chart depicting the scene. Then second is the table. This shows the year of study significantly affects the sleep quality, with students in higher years reporting poorer sleep quality. This is the bar chart for the scene. The third is the sleep duration significantly affects the sleep quality, while team study does not. Now coming to the clinical profile with the sleep quality, lower academic scores and self-reported health problems are significantly associated with sleep quality. This is poor sleep quality showing the how it is different. Next is the longer screen time is significantly associated with poor sleep quality, while bedtime coffee intake shows no significant impact. This is the same thing. Now coming to the discussion, poor sleep was significantly higher among urban or semi-urban students in our study compared to rural peers, showing a sharper domicile disparity than Sao et al. Similarly, both studies observed worsening sleep quality across academic years with comparable increases from first to fourth year study. Sleep duration, poor sleep increased from 59% to 97% in our study, similar to Singh et al., where 66.7 for less than 6 hours had poor sleep versus 38.7 for more than 7 hours. Academic performance in our study, 81.8% of students with 50 to 60% scores had poor sleep versus 84.6 in more than 80% of group, comparable to Sao et al., who found 83% with less than 60% versus 69% more than 80% scoring Sao et al. Self-reported health problems in our study, 85.1% of the students with health issues reported poor sleep versus 73.5% without, aligning with the OL et al. Screen time per day, poor sleep rose from 52.8% for less than 2 hours to 85.5% for 6 to 8 hours in our study, comparable to Verma et al., who reported 51% of poor sleep in our students with less than 2 hours screen time versus 83% in those exceeding 6 hours. Now coming to the conclusion, students from urban and semi-urban areas showed poorer sleep quality than rural peers. Short sleep duration, especially less than 5 hours, was strongly linked with poor sleep. Academic performance was inversely related to sleep quality, with lower scoring students reporting worse sleep. Health issues also contributed to poor sleep as did extended screen time, particularly beyond 6 hours daily. Addressing these factors, sleep habits, academic stress, health problems, and screen usage could enhance students' sleep quality and overall well-being.
Topic is open for the question and answer.
Your sample is from your medical students, and you have had significant difference in the rural and urban population.
Yes.
And most of these students were living on the campus.
Yes.
So I feel this is a little controversial result, because after a year staying in the hostel or at the campus, probably the difference between rural and urban background disappears, especially for these sectors. So I would like to take it with a pinch of salt, a lot of difference between the rural and urban students.
In your study, you have mentioned that poor health means like self-reported health problems. What kind of health problems students have been reporting?
So like people who are falling ill regularly and
The sleep disturbance may be because of the poor health, chronically ill, substance abuse, anxiety disorder, may have the depression. So have you included all the students having with the health problems in the sleep disturbances for this study, or you have ruled out those who have already?
any serious diagnosed cases were excluded from the study. Apart from that, if there were any health problem like because of
Why you have chosen coffee? Why not the alcohol? You mentioned that you have, like coffee is associated with sleep disturbances, alcohol use. Why not the alcohol and opioid? Why not the ganja, so very commonly used in the medical students? Why only nicotine is associated with the poor? What about the other substances? So it would be always better to use a structural performer to evaluate these findings. ना आप कोई भी तो सवाल पूछ करके you can't मतलब jump over the conclusion.
And after the study, did you look at the persons who volunteered for the study? Because there were some where there was a significant sleep quality problem. Probably, as a clinician, one should look back at those who had volunteered and re-educative or some kind of counseling for the group, that these are the factors, and if you take care of these things, you can be helped. So, somebody who has given you time for your study, one must spend some time to help those people. That's it. Thank you.
Dr. Shah, see, for all the PG students, whenever you present you prepare for the paper presentation, avoid the number of slides for the introduction. You have to write introduction in a single slide. Not need to go for the 3 slides, 4 slides. What is the need of writing the introduction in the 5 slides? So after 2 minutes, the introduction नहीं खत्म हो गया. So you have to give your emphasis over the methodology. Give your emphasis over the limitations or the conclusion part of discussion. Avoid text part of the result. Part diagram बना दीजिए, flow charts बना दीजिए. Avoid text. पढ़ रहे हो वहाँ पे इतने परसेंट में ये था, इतने परसेंट पाए. No need to do that. So always keep in mind whenever you present for the when prepare for the paper presentation.
Good morning, judges. I am presenting paper presentation on marital satisfaction in spouse of alcohol-dependent men, a cross-sectional study. The use of alcohol is not just a psychiatric or medical problem, but also a social one. Marital satisfaction is defined as a subjective evaluation of one's marriage in terms of happiness, fulfillment, and relationship quality, and is a key determinant of overall psychological well-being. Alcohol dependence is one partner often disrupts marital harmony, causing the spouse to experience emotional distress, domestic conflict, financial instability, and social stigma. There is a paucity of research examining marital satisfaction among spouses of alcohol-dependent men within the Indian context. And understanding this relationship is important to provide better psychological support and create helpful family-based programs that can improve marriage and overall family well-being. The aim of my study is to assess marital satisfaction in spouse of alcohol-dependent men, and objective is to explore the association between socio-demographic factors, marital satisfaction, and severity of alcohol dependence. The study was done in Department of Psychiatry at Nanta Medical College, Rajasthan. The study was cross-sectional study, and final sample size was calculated was 120, and the duration of the study is 18 months after the ethical clearance. The inclusion criteria of the study is spouse of all male patients who are more than 18 years and are willing to participate in the study and fulfilling the criteria of ICD-10, and participant married for more than 1 year and had active married life, and the exclusion criteria is patient having diagnosed psychiatric illness and or substance use disorder except alcohol, nicotine, and spouse with mental retardation, any serious medical illness, diagnosed psychiatric illness, and or substance use disorder. The methodology, sample selection procedure, a written consent in Hindi was obtained from both the patient and their spouse. After discussing the purpose of the study, the investigator then confirmed the couple's eligibility for the study by completing the screening form, and the data collected by and on socio-demographic and clinical variables were collected using a semi-structured performer, and the severity of alcohol dependence, alcohol use, mild, moderate, to severe, in the patients were assessed by SATQ, and the marital satisfaction in spouse was used by the Direct Adjustment Scale Hindi version, that is DAS, wherein higher the score, lower is the distress. and the statistical analysis was performed with the help of software SPSS 25. The results, the mean age of the spouse was 38 plus minus 8 years, and first table shows that socio-demographic profile of spouse of alcohol-dependent men. The education level mostly are literate, able to read and write, that is 32.5%. By occupation, mostly are homemaker, 60.8%. Socio-demographic, they are fall in middle class, that is 46.7%. Of 120 alcohol-dependent men, majority had severe dependence, around 64%, while 29% had moderate dependence and 7% had mild as per the SAT. For the group, the mean DAS-F score is 50 and standard deviation is 15, indicating moderate distress and significantly variability in the level of distress among the spouses. Majority, around 55.8% of spouses experienced severe relationship distress, while 34.2% had moderate distress level and 10% had mild distress level. The figure 1 shows that association of alcohol dependence severity on x-axis and with relation distress level on y-axis. The higher alcohol dependence in men is strongly associated with increased marital distress in the spouses. The table 2 shows the association between family type and relationship distress, and this shows the result is significant. The joint family has a more joint family is the protective factor in marital distress, and the discussion is the 55.8% of participants had severely distressed relationship, reflecting significant dissatisfaction, which is comparable with the study done by Halford and Oslo by 1993, and severe alcohol dependence was linked to severe distressed relationship in 55.8% of cases, while mild dependence correlated with better relationship outcome, which is comparable to the study done by Kishore et al. Spouses from nuclear family reported significantly higher relationship distress than those from joint family, which is comparable study by Nambi et al. The conclusion is, the study concludes that alcohol dependence in spouses significantly affect the marital relationship, with severe distress more common among women with the nuclear family. Higher alcohol dependence level were linked to the greater relationship dissatisfaction, and these findings highlights the urgent need for supportive interventions targeting spouse of alcohol users. Thank you.
Also, you who asked the question.
Explain two positive and negative predictors of marital satisfaction in your study. Explain two observed positive and negative predictors of marital satisfaction in your study. आपने जो स्टडी किया, आपने देखा कि आपके सेटिस्फैक्शन जो होता है ना फैमिली में, वो अल्कोहल से एडवर्सली अफेक्ट होता है। तो उसमें दो पॉजिटिव फैक्टर्स और दो नेगेटिव फैक्टर्स जो इस तरह के बैकग्राउंड को और सपोर्ट करता है, ऐसे आप क्या बता पाएंगे एज अ रिसर्चर?
Sir, nuclear family is the best predictor for marital satisfaction, and the alcohol dependency rate is also bad. And so it is joint family and lower the status for lower dependence.
जब भी कोई फैक्टर को हम पॉजिटिवली या निगेटिवली कोरिलेट करते हैं, है ना, एक फैक्टर पॉजिटिवली कोरिलेट है, तो उस फैक्टर का कितने परसेंट वो उस पर्टिकुलर चीज को एक्सप्लेन कर पाता है, उसको कोवेरिएंस कहते हैं। तो वो आपने कोवेरिएंस अगर आप निकालना चाहेंगे तो इसमें से कौन से फैक्टर का कोवेरिएंस निकालने की कोशिश करेंगे?
Family.
You have not mentioned the limitations in your study. आपको क्या लगता है आपकी स्टडी में क्या limitations है?
सर, एक small sample size है सर and
सैंपल साइज तो आपने कैलकुलेट करवाया है, तो वो सैंपल साइज स्मॉल कहाँ से होगा?
सर एक लास्ट
और कोई लिमिटेशन?
सर एक लिमिटेशन और हो सकता है कि जो ज्वाइंट फैमिली के स्पाउसेस है वो ना ओपनली अगर
सोशियो डेमोग्राफिक प्रोफाइल में मल्टीपल फैक्टर्स हैं। ऑक्यूपेशनल स्टेट्स दे सकते हो, इकोनॉमिकल स्टेट्स दे सकते हो, एजुकेशन लेवल दे सकते हो, और भी मल्टीपल फैक्टर्स हैं, तो उनको भी आप कोरिलेट कर सकते हो। आपने सिर्फ फैमिली टाइप को ही क्यों सेलेक्ट किया?
फैमिली का क्या इम्पैक्ट रहेगा सर?
आपने ये जो कंफाउंडिंग फैक्टर होते हैं, मैरिटल सेटिस्फैक्शन एक बहुत बड़े फैक्टर्स पे डिपेंड करता है। जैसे मैं छोटी सी चीज़ बताऊँ, एक पेशेंट है, उसकी एक वाइफ है और एक दूसरी वाइफ और रख रखी है घर में बिना मैरिज के। कई कास्ट है जिनमें आपको मालूम होगा कि रूढ़ीवादी प्रथा ये सब मौजूद है राजस्थान में भी। तो क्या दूसरी वाइफ के होते हुए मैरिटल सेटिस्फैक्शन हो सकता है? वही एल्कोहलिक नहीं है तो कंट्रोल आपने कोई प्रूफ क्यों नहीं लिया इस चीज़ को हटाने के लिए? ये सारे कंफाउंडिंग फैक्टर अगर आप वन शॉट अगर हटाना चाहते तो कंट्रोल प्रूफ लेते ना।
डॉक्टर उत्कर्ष,
Good morning everyone. Myself Dr. Psychiatry from Bangalore Medical College, Jaipur, UP. First of all, introduction. Borderline personality disorder is characterized by emotional, behavioral and interpersonal dysregulation. Borderline personality symptoms are also associated with difficulty in romantic relationships, including communication problems and more negative attributes for partners, behavior and aggression towards one's partner. When a person with borderline personality disorder senses a shift in their partner's feelings, whether real or imagined, they may immediately withdraw. They can become angry and hurt over something a person without BPD would not react to. These emotional switchbacks can be difficult to handle. Sometimes they can lead to uncomfortable public scenes. The impulsive behavior of a person with borderline personality disorder may put that person to their partner at risk too. Methodology. Aim the present study is designed to assess the marital adjustment and depression amongst the husbands of borderline personality disorder partners. Sample a total number of 50 spouses of BPD females were selected after meeting inclusion and exclusion criteria who were admitted in or attending OPD. Inclusion criteria for the patient was diagnosis as per ICD-10 and personality assessment scale 2 and age range between 20 to 50 years. Treatment more than 1 year. Exclusion criteria for patient was patient of any comorbid psychiatric disorder, other personality disorder or chronic physical illness. Inclusion criteria for spouses, average age between 20 to 50 years, educated at least 10th standard, living with patient more than 1 year, not using any substance. Exclusion criteria for spouses were presence of any comorbid psychiatric disorder or chronic physical illness, any legal issues with wife. The tools used were socio-demographic data sheet, a special design pro forma for collecting information about socio-demographic variable, marital adjustment questionnaire. It was developed by Kumar and Rohatagi. It is self-reported questionnaire, and Beck's depression inventory 2. It is revision of 1996 version, which was developed by Beck. Now the results. This is the socio-demographic details of spouses and socio-demographic details with BPD. The mean age of BPD spouses was 38.3 plus or minus 1.2 years, whereas in healthy controls spouse's age was 35.2 plus minus 2.3. Patient age was 36.2 plus minus 1.2. Healthy control age was 32.1 plus minus 1.2. Total duration of marriage in healthy controls was 5.2 plus and minus 0.3. Whereas in clinical groups it was 4.2 plus minus 1.2 years. This table shows the mean, standard deviation and p-value on marital adjustment of both groups. Findings indicate that there is a significant difference on marital adjustment in both groups. Spouses of female with PPD report poor or less marital adjustment compared to healthy controls. Total showing the mean and standard deviation p-value of both groups. Findings indicate that there is a significant difference on vexed depression inventory in both groups. Spouses of females with BPD reported more depression as compared to healthy controls. Now the discussion. It would be difficult for any marriage to survive if one partner was never sure how the other was going to function emotionally on a day or day-to-day basis. The present findings also support the previous researches, Midyear et al. Observed that the spouses with BPD reported lower marital satisfaction, where attachment, insecurity, more demand, communication problems, and also high level of violence are there. The role of family members significantly spouses caring for individuals diagnosed with BPD was expanded. Spouses experience significant distress related to the wife diagnosed with BPD problems. The majority of spouses report difficulty in caring for their partners diagnosed with personality disorders. They feel overwhelmed, unable to cope and exhausted by the stress. The burden experienced by a spouse with a borderline personality disorder partner have been noted to greater than those with other mental disorder. However, the stability of a partner may have a positive effect on the emotional sensitivity of people with BPD experience. It may require a great deal of work from both partners so that long-term relationship and marriages are possible for people with BPD. Conclusion: although marriage in different cultures are different, but still there are some common bases like mental health of the couple as the basic factor which go beyond the cultural differences. Therefore, with regard to the results focused on spouses' mental health is also important, and they also need social and emotional support. The best point of the improvement that spouses know that they can have a healthy relationship despite their partner's personality disorder. Treatment along with a strong support network can help spouses find stability in their partner's emotional state and in relationship.
Any question? Again, you have not mentioned the limitation of your study. What are the common limitations?
So demographic profiles, other demographic profiles can be added, sir, and the more number of participants can be taken.
What was the sample technique of your study?
So it was a cross-sectional study.
Sampling technique.
The questionnaire was used, sir.
Sampling technique. Thank you.
साइकियाट्रिस्ट हमेशा ये बात करते हैं कि कोई मिथ जो चल रही है वो नहीं होनी चाहिए, कोई जनरेट नहीं होनी चाहिए। आपने इसमें आर्टिकल में लिखा है स्पाउस ऑफ बीपीडी, लेकिन आपने टॉपिक से फीमेल के स्पाउस लिए हैं, मेल से बीपीडी नहीं होता है,
सर होता है।
तो वो क्यों नहीं लिए? फीमेल स्पीक को हम ये करना चाहते हैं, फीमेल बीपीडी भी होगी तो मेल को दिक्कत होगी। मैं ये नहीं कहता आप स्टडी में ठीक है जेंडर स्पेसिफिक ले सकते हैं, लेकिन हम एक नैरेटिव सेट नहीं करें इस तरह का। वे दोनों जेंडर लेके तो ठीक है, वो दोनों संख्या कम आ जाती है। मेल्स की ओपीडी में अगर आपने देखा हमारे गवर्नमेंट हॉस्पिटल आते हैं अच्छे खासे, इतने कट्स होते हैं कि रिवील भी नहीं लगाते, इतने कट्स लगाए रहते हैं। इमोशनल इश्यूज बहुत होते हैं उनके साथ भी आज।
So recording our opinion consider करना।
Now we call upon Dr. Abhishek Vashisht.
Good morning everyone. I am presenting a study of radiological, socio-demographic and clinical profiling in psychiatric Psychiatry Center. In introduction, India, the most populous country in the world, the proportion of those 60 years older is 5.4% in 1951, increased to 8% in 2010. The United Nations indicated to 25.0% of the population will be age 60 plus by 2050. Aging brings various mental health challenges, including increased psychological distress due to loss of intrinsic capacity and comorbidities, which often require multiple medication. Late onset psychiatric disorders such as depression, anxiety, and cognitive decline can significantly impact physical health and social score. This study aims to analyze the socio-demographic, radiological, and clinical profiles of geriatric patients at a tertiary care center to identify the patterns and correlations that could improve the management of aging-related mental health conditions. Geriatric psychiatric disorders often present with complex clinical features that may include cognitive decline, affective symptoms, and psychosis. Incorporating radiological findings into psychiatric assessment provides valuable insights into underlying neurological conditions, particularly in late onset cases. Understanding the interplay between socio-demographic, clinical, and radiological factors is essential for improving diagnostic accuracy and management strategies in older adults. Objectives: to determine the socio-demographic profile of patients above 60 years presenting to psychiatric OPD, to study the clinical profile of patients above 60 years presenting to psychiatric OPD, scales to be applied, GHQ-12, MMSC, MA, MD, and BPS. To determine the radiological profile of patients above 60 years of age presenting with psychiatric illness, including criteria. Patients presenting to the psychiatric OPD IPD above 60 years of age, participants, relatives who had given intuitive informed consent to participate in the study, patients of both genders of age above 60 years were included. Exclusion criteria: patients with significant neurological, medical, or surgical illness, patients or key relatives who had not given written informed consent. Study area: the study was conducted in the Department of Psychiatry at Psychiatric Center in Rajasthan. Study population: patients above 60 years of age presenting in the Department of Psychiatry at Psychiatric Center in Rajasthan. Total sample size 62. Sampling technique: purposive sampling technique. Study design: cross-sectional study. इसकी methodology: permission लेने के पहले first we take the permission from scientific industry committee and institute, and on the basis of inclusion and exclusion criteria, patients of above 60 years of age were included. Written consent from the patients and their attendants was obtained after explaining the study to the patient. Socio-demographic data was obtained on the specially designed semi-structural proforma consisting of clinical and demographic profile. Diagnosis was made according to ICD-10 criteria. Mini-mental status examination was done to detect cognitive impairment. Hamilton Anxiety Rating Scale, Hamilton Rating Scale for Depression were applied to assess severity of anxiety and depression respectively. Brief psychiatric rating scale was applied in psychotic patients. Neuroimaging was done, and the study employed proposing sampling techniques, and data was analyzed using appropriate statistical methods under supervision of statistician. Observation and research. Sir, out of my 62 patients, 24 patients were found having depression, which is 38.7%. Generalized anxiety disorder is 17 patients, 27.4%. Somatoform disorder is 9 patients, 14.5%. Bipolar affective disorder, only 5 patients were of BPD, with 8.06%. Depression and psychotic features, 3 patients, 4.8%. Obsessive compulsive disorder, 1 patient, which is 1.6%. Post-traumatic stress disorder, 1 patient, 1.6%. Opioid dependence के 2 patients थे, 3.2%. और डिमेंशिया का 1 patient था, 1.6%. जिसमें हमने MMSC की स्कोरिंग करी, तो जिसमें नो इम्पेयरमेंट सर्टिफाइड पेशेंट्स में 23 से ज़्यादा स्कोर आया, और 24 पेशेंट्स में 18 से 23 के उसमें स्कोर आया, और सिवियर इम्पेयरमेंट 3 पेशेंट में 17 से कम स्कोरिंग आई थी, और इसमें हैमी में सर 5 पेशेंट्स में माइल्ड एंजाइटी है, 7 पेशेंट्स में से सर मॉडरेट और सीवियर एंजाइटी 5 पेशेंट्स में थे इससे 17 एंजाइटी वाले पेशेंट्स में से। और सर हैमडी में से 24 डिप्रेशन पेशेंट में, माइल्ड डिप्रेशन 3 पेशेंट्स में आया था, मॉडरेट डिप्रेशन 16 पेशेंट्स में और सीवियर डिप्रेशन 5 पेशेंट्स में सर। और बीपीआर से 3 पेशेंट्स का लगाया था सर, मैं डिप्रेशन पीएफ वालों में, जिनमें 3 में माइल्ड लगाया सर। और सर एमआरआई फाइंडिंग्स में सर वाइट माइटर हैपेंड सर सबसे ज़्यादा आया है हमारे पास स्मॉल वेसल इस्मिक चेंजेस, जो कि सर 58% था। उसके फॉलोड बाय सर वाइट माइटर हैपेंड इंटेंसिटी 28 पेशेंट में 45%। और सर हाईएस्ट आया सर उसमें कोर्टिकल एट्रोफी आई है 70.9%। और सर ओनली 11 पेशेंट्स हैज बीन नॉर्मल एमआरआई एग्जामिनेशन स्टडी है डिस्कशन। A total 62 patients were included in our study. The maximum number of elderly 67.7% in the study was in the youngest age group 61 to 70 years, and with the least number in the oldest age group was more than 80 years, 8%. These findings are consistent with the study of by Nair et al. And Sebi et al. 105. In our sample, the burden of psychiatric disorder was higher in female, that is 61.2%. Almost 2/3 of the participants were married, and more than 1/3, 33.9% of the participants were widowed. These findings are consistent with the study by Midyear et al. In our study, 77.4% of the population belonged to the middle class and 19.3% belonged to the lower class strata of the population. Poor status of the family might be responsible for the disturbed sleep pattern among those living with family members. Around 2/3 of the study population was educated and uneducated. Around 1/3 were educated up to primary education in our study. These findings are similar to the study under Srivastava et al. 7, where among the participants 69.9% individuals had no formal education, 23.3% individuals were literate, and 6.8% individuals had completed education up to primary. सर कंक्लूजन में ये है कि सर 61.2% हैं सर वो फीमेल्स हैं इसमें से। और सर जिसकी इनकी एज ग्रुप 61 to 70 ईयर्स है सर, मेजोरिटी आर मैरिड है सर। 38% में डिप्रेशन है और 27.4% में सर जनरल एंजाइटी है सर। और सर 38.7% पीपल में सर एनएलसी स्कोर सर अच्छा आया है। और सर 70.9% पेशेंट में कोर्टिकल एट्रोफी आई है और फॉलोड बाय स्मॉल वेसल्स में चेंजेस आई है 58% में सर, और वाइट मैटर हाइपरटेंसिव आई है 45.1% में। और सर 11% पीपल की सर नॉर्मल स्टडी है।
To ask the question.
My first question is that you haven't taken any comparator arm. Study में कोई comparator arm तो है नहीं. You can compare with there is no control arm. So all the findings that you have mentioned here, how could you attribute it to any sort of psychiatric disorder? It can be there in normal population also. Radiological finding, the most common radiological finding that you open the tower of the teeth. Most of them have mild chronic ischemic changes, cortical atrophy. Above 60, it's quite common. So what is the new finding that you wanted to point out in your study? Radiological findings are the same in the population. And you can even compare with the normal population. What is the significance of your study? Why did you perform this study? What is the...
Just to correlate between psychiatric patients.
When you didn't correlate between anxiety or whether depression, any sort of psychiatric disorder, you didn't compare with the radiological findings. Did you? So what is the purpose of doing radiological findings if you didn't even compare with the psychopathology? That whether the radiological findings corroborate with the specific disorder or not. It's just like that as if I am an OPD and I am doing CBC and electric to everyone, but I am not concerned about their findings. So what is the correlation? How did you corroborate the psychiatric findings with the radiological findings? What is the purpose of doing radiological findings?
सर वही सर हर 60+ पेशेंट के साथ हमने रेडियोलॉजिकल इमेजिंग करा तो देख रहे हैं कुछ स्पेसिफिक चेंजेस आए हैं।
In your study, you have mentioned that dementia was found in one patient, but in MMSE scores, moderate to severe impairment was seen in 27 patients. So why they have not been categorized under the dementia?
Because sir most of the patients are illiterate, they don't know, they don't answer score well in the
Then which tool you will use to evaluate the cognitive function in pediatric age group in illiterate patient?
Next we have Dr. R.M. Kotia from Mahatma Gandhi Medical College and Hospital.
Good morning, everybody. I'm presenting my poster on the topic of practice study of sleep quality and its associated factors across different years of postgraduate medical training at a tertiary care hospital in Rajasthan. So basically, sleep is a fundamental biological process. We all know it's essential for physical restoration, cognitive performance, and emotional well-being. Postgraduate medical students, they are more prone to long duty hours, rotating shifts, academic workloads, and emotional stress, which affects their both personal well-being and clinical efficiency. So we need to understand year-wise differences and the associated factors such as gender, work schedule, screen time, stress, that we can actually help with a targeted intervention to improve resident wellness and prevent any psychiatric disorder. The need for this study was postgraduate medical students, as I said, face unique stressors, irregular duty hours, academic pressures, and lifestyle disruptions. We need to identify what associated factors across training years can guide targeted intervention to improve well-being, prevent burnout, and enhance clinical performance in this vulnerable population. So the aim was to assess and compare sleep quality and its associated factors across different years of postgraduate medical training at a tertiary care hospital. The objective was to evaluate the prevalence of poor sleep quality among postgraduate medical students using the most PSQI, Pittsburgh Sleep Quality Index. Then to compare sleep quality scores across different years of postgraduate medical training, first, second, and third years, and then to identify behavioral and academic factors that are associated with the poorer sleep quality. The study design was a cross-sectional type of study. It was conducted at Mahatma Gandhi Medical College and Hospital in Jaipur. Duration of the study was 3 months. The sampling method was convenient sampling. The sample size was 315 medical PG students enrolled from tertiary care hospital in Rajasthan, and due approval was taken from ethical committee of the institute. The tools used: the socio-demographic characteristics, age, gender, year of post-graduation, specialty, and accommodation type. The Pittsburgh Sleep Quality Index was used for sleep quality. It's a validated self-report tool assessing sleep quality over the past 1 month. It evaluates 7 components: subjective sleep quality, sleep latency, duration, habitual efficiency, disturbances, medication use, and daytime dysfunction. The scores range from 0 to 21. This is the scoring: 0 to 5, very good sleep quality; 6 to 10, fairly good; 11 to 15, fairly bad; and then 16 to 21, very bad. The inclusion and exclusion criteria. The inclusion criteria were postgraduate medical students currently enrolled in any clinical or paraclinical department, and they were willing to participate and they provided informed consent. The exclusion criteria: the students did not complete the questionnaire and the students unwilling or unable to provide the informed consent. So this was the distribution of sample. Total residents enrolled for the study 371, total approached and consented to participate was 337. Forms excluded due to incomplete details or exclusion criteria, there were 19, and then the final forms included for final analysis was 315. Software used: data was entered in Microsoft Excel and analyzed using the SPS version 16. Tests were mean plus minus standard deviation for continuous variables and the chi-square test to compare mean score of categorical variables. P-value of less than 0.05 was considered statistically significant. This is the first anthropometric profile and the related parameters of participants. So total number of participants was 315. Their mean age was 27 plus 0.5 plus minus 3.3. Males were 155, females were 160, PG1 were 119, PG2 were 82, and PG3 was 109. This is the component-wise distribution of PSQI subscales and sleep quality indicators among the postgraduate. So subjective sleep quality, sleep latency, duration, sleep efficiency, sleep disturbances, and medication and daytime dysfunction. So sleep duration and latency were the most affected domains, indicating difficulties in maintaining sufficient and timely sleep. Significant daytime dysfunction and disturbance reflect the clinical impact of the compromised sleep. This is the cross-tabulation of sleep quality categories across different PG years. Sleep quality appears poorest among PG1 and then PG3, suggesting a U-shaped trend in sleep disturbances across training years. These findings highlight the need for targeted intervention during both entry and exit phases of residency. The inference of this table, the distribution of associated factors contributing to poor sleep among postgraduate medical students. These findings emphasize the need for targeted intervention such as improving sleep hygiene, maintaining digital behavior and regulating duty hours, and enhance the living conditions to reduce the burden of sleep disturbances. In this table also you can see the scrolling, social media before bedtime is a very big factor. The environmental disturbances such as sharing of room, the parties in the hostels also contribute to a major factor. The discussion, a significant proportion of students, approximately 138 out of 315 reported only fairly good sleep, while 104 participants rated their sleep quality as fairly bad and 40 good participants very bad. These findings align with the previous research conducted in Indian medical institutions, which reported that over 60 to 70% residents experience poor sleep quality, often due to academic and clinical demands. The majority of the participants reported 5 to 7 hours per night, 41 participants getting less than 5 hours, and the year-wise, as I highlighted, PGY1 showed slightly higher prevalence of poor sleep quality, which was followed by PG3 and then PG2. The night duty and shift work, more than 80% reported having 1 to 3 night shifts per week. The conclusion study reveals a notably high prevalence of sleep quality among postgraduate medical students, with junior residents being disproportionately affected. Key factors include academic workload, irregular duty hours, maladaptive lifestyle patterns such as scrolling social media before bed. These findings highlight the pressing need for institutional intervention such as structured duty hour regulation, accessible mental health services, and target sleep hygiene education. Implementing such measures is essential to safeguard the well-being, clinical performance, and long-term health of medical fields.
Topic is open to ask the question.
आपने ईयर वाइज कंपैरिजन किया है, ब्रांच वाइज कंपैरिजन किया है क्या?
नहीं सर, ब्रांच वाइज कंपैरिजन करना एक्चुअली सर थोड़ा डिफिकल्ट हो जाता है, बिकॉज देन द ब्रांच डिफर फ्रॉम ईच अदर इन टर्म्स ऑफ देयर इरेगुलर ड्यूटी आवर्स. Most of the clinical branches have very different aspects from the non-clinical branches.
इवन क्लिनिकल ब्रांच में जैसे डर्मेटोलॉजी है, उनके अंदर इमरजेंसी ड्यूटीज नहीं होती. एक आजकल एनएमसी ने शायद ऐसा किया है, हमारे पता नहीं है, कि इमरजेंसी ड्यूटी आपकी एक फिक्स पीरियड में लगती है.
So this is सर ये
जैसे आपने जिस पेशेंट का जिस टाइम सैंपल लिया उस टाइम उसकी ड्यूटीज कहाँ चल रही थी, ऐसा आपने स्पेसिफाई किया है जस्ट टू रिमूव द कंपाउंडिंग फैक्टर्स?
नो सर, हमने ये मेंशन करा कि एक उस वीक में उस रेजिडेंट की कितनी नाइट ड्यूटीज थी सर, क्योंकि सर नॉर्म्स जो होते हैं और जो एक्चुअल प्रैक्टिकल ड्यूटीज में सर थोड़ा बायस आ जाता है सर कभी कभी. उस वजह से सर मैंने एक वीक का लिया था रादर देन पर रेजिडेंट विद पर ड्यूटी.
आई थिंक आपकी स्टडी अच्छी है, एम्स ऑब्जेक्टिव क्लियर है, एनालिसिस का वे भी बहुत अच्छा रहा. मुझे लगता है कि आपने इसमें एक एफ स्केल यूज़ करना चाहिए था, जो कभी कभी ना मेडिकल स्टूडेंट्स या पोस्ट ग्रेजुएट्स फॉल्स रिपोर्टिंग भी कर सकते हैं, है ना. आपको कैसे पता कि ये सच है या नहीं है?
राइट.
तो एक
So that was my one major limitation. The performer that I designed was that would have biases, the self-reported bias that would have that definitely.
दूसरा है लास्ट में कि जो आपके 160 प्लस लोग जिनमें स्लीप डिस्टर्ब हुई है, उनके लिए आप क्या करना चाहोगे?
So first, identification is very crucial, sir. Identification over the years is very crucial. PG Y1 and PG3. सो जिससे कि एक तो स्क्रीनिंग मेथड्स हम यूज़ करें सर, भाई फर्स्ट ईयर में कोई रेजिडेंट आ रहा है तो उसको ऑलरेडी हम स्लीप हाइजीन के लिए एजुकेट करें. ड्यूरिंग द आइडेंटिफिकेशन वी कैन एक्चुअली टेल देम अबाउट द स्लीप हाइजीन ऑल्सो सर, बिकॉज वी नाउ हैव द सोशल डेमोग्राफिक्स सर, सो वी कैन एजुकेट देम.
लास्टली जो लोग इंटेंसिवली कोई नई चीज़ सीखने की कोशिश करते हैं या सोसाइटी को सर्व करते हैं, उसके अंदर एक सेल्फ एक्सप्लोरेटरी और सेल्फ डिनाइग्रेटरी या सेल्फ डिफेटिंग फैक्टर्स ऑन होते हैं, जिसकी वजह से इजी स्लीप नहीं होती है.
राइट.
तो हम लोग वो जो फैक्टर्स होते हैं उसको बैलेंस करने के लिए जब इक्वेशंस में लगाते हैं तो उसको कौन सा statistical method use कर सकते हैं? It's a difficult question.
So, I will be very honest, I don't know the answer to that, but then the sleep scale that I used had the trends over the past 1 month. So that trend of the past 1 month can actually help me remove the biases that can occur on a daily basis.
My question has already been asked by Dr. Vinod, but to extend it, you say stark difference between non-clinical and clinical branches. And if you have, in your study, because you have also conveyed the effect of shift duties. तो क्लिनिकल डिपार्टमेंट्स के अलावा जो नॉन क्लिनिकल डिपार्टमेंट्स हैं वहाँ तक मुझे आपको स्कूल का पता नहीं, बट शिफ्ट ड्यूटीज का तो कॉन्सेप्ट नहीं होता है नॉन क्लिनिकल डिपार्टमेंट्स, फॉर एग्जाम्पल एनाटॉमी हो गई आपकी. तो अगर आप जो ड्यूटी शिफ्ट है या फिर इफेक्ट ऑफ शिफ्ट आवर्स ऑन स्लीप इसको हम कंपेयर करेंगे तो वो थोड़ा सा ट्रबल क्रिएट कर देगा, क्योंकि आपके नॉन क्लिनिकल डिपार्टमेंट्स तो है ही नहीं.
डेफिनेटली सर, नॉन क्लिनिकल और क्लिनिकल में सर काफ़ी स्टार्क डिफरेंसेस हैं सर.
कल बेटर होता कि अपन को ना एक कंपेरेटर आर्म बना देते क्लिनिकल वर्सेस नॉन क्लिनिकल.
राइट.
उसमें और अच्छी चीज़ें कर दिया.
राइट.
Thank you. Next, Yogita, Dr. Yogita.
Good morning everyone. I am Dr. Yogita Kesavan presenting a cross-sectional study conducted under the guidance of Dr. Manju ma'am at Mahatma Gandhi Medical College and Hospital. The study focuses on assessing the prevalence of depression, anxiety and suicidal ideation among transgenders. Transgender individuals face significant psychosocial stress due to stigma, discrimination and lack of inclusive healthcare. These factors have been linked to high rates of depression, anxiety and suicidality in previous studies, both globally and in India. Despite some legal reforms, there is limited empirical data on the mental health of transgender individuals in North India. This study attempts to bridge that gap by focusing on psychological distress in this group. Aim of the study was to assess depression, anxiety and suicidal ideation among transgenders. Objectives: to estimate the prevalence of depression, anxiety and suicidal ideation among transgenders and to examine the key psychosocial factors associated with these conditions. Material and methods: study design was cross-sectional, place of study Mahatma Gandhi Medical College and Hospital. Duration of study 6 months. Sampling method that was used was snowball sampling. Sample size was calculated up to 200 and due approval was taken from the Institutional Ethics Committee. Inclusion and exclusion criteria. Inclusion criteria: self-identified transgender individuals aged between 18 to 65, willing to provide informed consent and ability to understand and complete the online questionnaire. Exclusion criteria: individuals with known medical comorbidities or incomplete or duplicate survey responses. Tools used: personalized social demographic proforma, Hamilton Depression Rating Scale, Hamilton Anxiety Rating Scale and Suicide Behavior Questionnaire. Statistical analysis: descriptive statistics like frequencies and percentages were used to summarize the socio-demographic variables. Inferential statistics: chi-square test was used to assess association between categorical variables, and binary logistic regression was conducted to explore associations between mental health variables and suicidal ideations. A p-value of less than 0.05 was considered statistically significant. This table presents the subgroup-wise prevalence of high anxiety and depression. Individuals with no formal education experience the highest levels of mental distress, 66% with high anxiety and 60% with depression. Among the sex workers, anxiety was also significantly high at 59% and likely due to exposure to violence and economic insecurity. Continuation with the previous table, participants living with the guru, a traditional but socially isolated living situation, had the highest depression rated 48%, highlighting the emotional toll at isolation, and substance use appears to be worsen mental health outcomes. 57% of daily alcohol users reported high anxiety and 40% reported high depression. Another table where we see the distribution of suicidal ideation or attempts among various subgroups. The highest rate was among those whose main income was begging. Nearly 62% reported suicidal thoughts. Living with the guru was also linked to a high rate of suicidality at 56.3%, which aligns with earlier findings on depression. In continuation, people with a history of migration or unstable relationships also showed elevated suicidality, and the strongest associations were found with mental health status itself. 63.2% of individuals with high depression, 48% with high anxiety reported suicidal ideation, emphasizing the importance of addressing mental health proactively in this population. Our findings are consistent with existing Indian studies that report similarly high rates of depression and suicidality in transgender population. The results underline the urgent mental health needs of this group, especially those facing social exclusion, unemployment or substance abuse. Living conditions, lack of familial support and being disconnected from formal education seem to significantly exacerbate mental distress. This calls for both community level support and systemic policy intervention. Limitations of this study was that it is a cross-sectional study, so it is a snapshot in time which limits the ability to form a causal relationship. It is a self-reported data, that's why it can introduce recall bias. Online and snowball sampling may have excluded individuals without the internet access or those who are not connected to these networks. And they are based on a North Indian urban sample, may not fully represent the broader transgender population, and there is lack of clinical verification as no psychiatrist could clinically diagnose depression and anxiety. Conclusion: this study confirms previous findings reporting high rates of anxiety, depression and suicidality among transgender individuals, supporting the need for targeted and inclusive mental health care. Urgent need for immediate clinical attention, inclusion of transgender focused services, routine screening, counseling and creating of affirming supportive environments. Thank you.
To ask the question.
अच्छी स्टडी है। इनफैक्ट हमारी थीम को रिफ्लेक्ट करती है। आपने 200 सैम्पलिंग सैंपल साइज एनालाइज किया, तो 200 साइज कैसे निकाली?
Sir, there are various previous studies जो साउथ इंडिया में हुई थी. According to them, उनका prevalence around 0.4 to 5 के बीच में था, and using the sample size sample size का formula and keeping the margin at 0.7, it was approximately coming 188 to 190.
बट जब हम स्नोबॉल सैम्पलिंग करते हैं तो स्नोबॉल सैम्पलिंग में it is very difficult to identify if you are actually able to figure out the precise sample in the process or not. That's one of the difficulties.
So that is what, when we started doing the study, so we wanted to know we knew what population we are targeting, but we did not know that how much sample size would be accurate.
Second issue is you have 40% of them were sex workers and almost 60% of them were beggars. So apparently अगर इस तरह का population है जहाँ पे आप मतलब beggars को और sex workers को identify कर रहे हो, तो आपको anxiety, depression और suicidality के ideologies तो मिलेंगी, है ना? और आपकी इसमें 33% depression आया और anxiety थोड़ा ज़्यादा आया 40% के अराउंड. बट सुसाइडलिटी जो है वो डिप्रेशन से भी ज़्यादा आया, तो एंजाइटी वाले पेशेंट्स को
सुसाइडलिटी हम कंपैरेटिवली देख रहे हैं कि एंजाइटी, जिन पेशेंट्स ने एंजाइटी रिपोर्ट करी और जिन पेशेंट्स ने डिप्रेशन रिपोर्ट किया, तो कंपैरिजनली हम वो देख रहे हैं कि वो
एंजाइटी वाले पेशेंट्स को सुसाइडलिटी सच में आती है क्या?
बट सर मे बी एंजाइटी का कॉज क्या है, उसके रिलेटेड थॉट्स, एंड मे बी एंजाइटी एंड डिप्रेशन आर कोएग्जिस्टिंग।
लास्टली हमेशा प्रिवालेंसेस जो है ना 1000s में निकाले जाते हैं हमारे मेंटल हेल्थ में। जब भी आप देखो एपिडेमियोलॉजिकल डेटा, आपके प्रिवालेंसेस फिगर्स अगर आप 200 का सैंपल लेते हो तो इज इट अ गुड वे टू रिपोर्ट अबाउट द प्रिवालेंस इन ऑब्जेक्टिव? If such is the problem, what kind of a deficit in the validity we use in the word to denote it?
अप्रोच कैसे किया सैम्पलिंग आपके लिए?
सर जैसे हमारी ओपीडी में कुछ ट्रांसजेंडर इंडिविजुअल्स आते हैं, तो हमने उनको क्वेश्चनियर भरने को बोला था, एंड फिर स्नोबॉल सैम्पलिंग मेथड से उनके सोशल नेटवर्क से वो ऑनलाइन क्वेश्चनियर उन्होंने भरा था।
आपके जो बहुत सारे से जो आपके सैंपल्स में जो ट्रांसजेंडर्स हैं, बहुत सारे से जो बैटिंग करते हैं,
यस सर, यस सर,
और बहुत से आपने इस बात की है कि मोस्ट ऑफ देम बिग इलिटरेट,
यस
इलिटरेट पर्सन्स को आपने ऑनलाइन फॉर्म कैसे बनवाया?
सर वही बात है कि हमारे जो एक्सक्लूजन क्राइटेरिया था और इंक्लूजन क्राइटेरिया में था, उसमें हमने ये चीज़ मेंशन करी थी कि जो हमारे इनकम्प्लीट फॉर्म्स आए थे हमने उनको एक्सक्लूड कर दिया था।
Do you think that those who are begging on streets, they were having internet connection and they were able to fill the forms?
सर बेसिकली जो ट्रांसजेंडर इंडिविजुअल्स हमारी ओपीडी में आ रहे हैं उनके बहुत स्ट्रॉन्ग सोशल नेटवर्क्स होते हैं, सो दे हेल्प ईच अदर आल्सो इन दीज थिंग्स। तो जो
हेल्पिंग ईच अदर की बेसिस को क्या मानना है?
सो यस सर, वो एक लिमिटेशन है स्टडी की, सेल्फ रिपोर्टिंग डेटा है तो, और वो भी एक दूसरे की तो उसकी वजह से।
आपने बायोलॉजी की जो लॉजिस्टिक रिग्रेशन लगाया है, कैसे लगाया? कौन से टूल का यूज करते हो?
सर
बाइनरी लॉजिस्टिक रिग्रेशन है, कैसे यूज किया आपने?
सर बाइनरी लॉजिस्टिक रिग्रेशन दो कैटेगरीज हाँ जी।
What tool did you use to perform a binary logistic regression? किया होगा क्या?
है सर, इसमें
कौन सा वर्जन चल रहा है करेंटली? और आपने कौन सी यूज किया?
Thank you. Next presentation, Dr. Himanshu Helawat.
Good morning everyone. Today I am going to present my study findings on the topic of treating pattern of patients with alcohol use disorders. Introduction. Alcohol being the most widely used substance in the world, resulting in mental and medical consequences. Chronic drinking interferes with person's ability to conform to social rules governing daily activities such as keeping up appointments, caring for children, performing a job properly. They are typically expected the person's reference group. According to recent estimates of the World Health Organization Expert Committee, alcohol is estimated to cause a net harm of approximately 3.7% of all the deaths and 4.4% of the global burden of the disease. The study aim was to assess the drinking pattern in patients with alcohol use disorder, with objectives being to analyze the social demographic correlates such as education, occupation, marital status and family sizes, to quantify patterns of alcohol consumption including daily intake, duration of use, to evaluate the financial burden of alcohol expenditure and its impacts on dependence severity, to assess the contextual factors influencing the alcohol use such as time of drinking, social settings and self-reported motivations like relaxation, to measure the severity of alcohol dependence using the severity of alcohol dependence questionnaire. Materials and method. It was a cross-sectional study done at Mahatma Gandhi Medical College, Jaipur for 3 months. Then the sampling method used was the convenient sampling and a sample size of 146 was taken when a due tool was taken from the institutional ethics committee. Inclusion criteria, it included all the males who met the diagnostic criteria for alcohol use disorder as per the DSM-5, age above 18, and exclusion criteria was the patient who has any other substance abuse except nicotine, patients who are not willing to give consent, presence of any psychiatric illness that prevents them from participating in the interview. Tools that were used, there were semi-structured, socio-demographic and clinical performer, and severity of alcohol dependence questionnaire. Distribution of the sample. Total of 146 patients enrolled for the study, out of which 100 gave the consent, further on which they were assessed using the semi-structured questionnaire and the severity of alcohol dependence questionnaire. 46 of them were excluded from the study because they were not willing to give the consent, and the other had the history of any other substance like cannabis. So final forms included for the final analysis were 100. Statistical analysis scores were computed on age scale and subscale parameters. The data was analyzed using descriptive statistics. We analyzed the data using Excel for descriptive summaries and charting. This is a pie chart showing the educational status of the patient. The chart shows that the majority of the patient has education up to the secondary level, followed by those who are illiterate or had primary education. Very few had a higher education. This suggests lower education might correlate with the higher alcohol misuse. The second figure shows the majority of them were unskilled workers, followed by the unemployed individuals. Only a small number had skilled government jobs. This implies that economic instability might be a driving factor for the sustained alcohol use. And the third one was the religion of the patient. Most participants were Hindu, which simply reflects that the regional demographic of Jaipur might not be suggest a strong correlation between the religion and the alcohol use. The figure 4 shows the marital status of the patient. A large number of patients were married, suggesting family responsibilities may not necessarily deter alcohol use. This raises a concern about its impact on families and dependents. Fifth figure shows the family size. Joint and large families were the most common. Despite having more family members, this does not act as a protective factor for alcohol consumption. Peer influence or family stress might be contributing to the continued drinking behavior of the patients. This is a table showing the alcohol use detail of the patient. The findings, the majority findings of this table are the mean age of the onset of alcohol consumption was 23.5 years, while the mean duration of alcohol use was 25.7 years. Daily drinking was reported in almost 69% of the patient, and an average daily intake of alcohol was 381 ml, and the average monthly spend was around 3,500. This shows long-standing, consistent, and financial burdensome use. Other associated factors in alcohol use. This is the table. This shows the craving was reported in around 82% of the patient. Withdrawal symptoms were seen in around 78% of the patient. Majority of the people drank alcohol for relaxation, stress relief, primarily in the evening with friends. These contextual triggers are important for tailoring interventions. This is a pattern shows the alcohol use, reason to consume alcohol, decision to drink, usual times of consumption, usual place of consumption. The previous table showed that 66% of the people drank to relax, 65% of the drink with the company of friends, and 42% drink in the evening. This supports the pattern of social and emotional involvement. The table 4 shows the severity of alcohol dependence, with 47 had mild dependence, and 43 had moderate dependence, and 10% had a severe dependence. This wide distribution helps us in understanding the treatment needs across a spectrum from counseling to detox. Talking about the discussion, paternal literature comparison. The mean age of alcohol use initiation in our current study was 23.5 years, which is inconsistent with findings from an Indian community-based study, which reported a mean age of onset of 21.5 years. This supports the observation that alcohol initiation that occurs in the childhood, chronic use with withdrawal in 78% meets the DSM criteria for a severe alcohol use disorder, highlighting neuroadaptation risk. Talking about the social and economic determinants, the prevalence of social drinking with 65% occurring in peer settings suggests that environmental reinforcement may play a role in maintenance of addictive behaviors. Limitations of my study. It was a cross-sectional, so associations were noted, but the causality cannot be inferred. It was a single-center study, so it limits the generalizability. Replication needed to be in diverse settings. All of them were male samples, excluding the gender-specific alcohol use disorder patterns, and no inferential statistics have been applied. To conclude, there was around early onset of drinking was seen in 23.8.
Thank you. House open to answer the question. What was the need of the study?
So the need of the study was to finding the various triggers that are present, where the severity, if we have seen the SAD2 scores, that indicates that the mild patient needs early intervention. The moderate severity level indicators require a structured therapy, and those had a severe dependence require a severe medical inpatient detoxification, and various trigger factors that act as a risk factor in alcohol consumption rather than similarly to understand the fact that if we are expecting it will be larger family group, so it is a larger family than a joint family, the person is expected to be more responsible, taking responsibilities of the other family member, but that didn't stop people from drinking alcohol.
You have mentioned the certain regions of alcohol use. On what ground you have selected these regions? Have you asked openly that what was the reason of your alcohol dependence? Or any structured performance?
There is a structured performance which included all these questions.
What was that?
Social development, self-structured, does not any approved scale or say SAD2 was applied for.
Subjective ना उनको पूछा आपने कैसे आपने शराब क्यों स्टार्ट करी तो उसने बोला कि पैसे नहीं थे, तनाव था, नौकरी नहीं है, तो आपने मेंशन कर दिया.
Yes.
अल्कोहल की आपने एवरेज डोज 381 शायद है.
Yes sir, 380.
वाई इसकी सबने अलग-अलग किया, कैसे किया उसको? 380 ml क्या इक्विवेलेंट डोज करिए कैसे?
Approximately percentage.
एक तो जना थिंग लेगा 381 ml एक.
Yes sir.
लेगा.
Yes sir.
फाइंडिंग्स क्या आपकी? इतनी बहुत बड़ी लिमिटेशंस थी कि ये अगर 4% है और ब्रांडी में 40% होती है. मैंने ये भी देखा कि मोस्ट ऑफ द पीपल आर ड्रिंकिंग ब्रांडी एंड ब्रांडी को फॉर बैक शॉप बिल्कुल भी नहीं है ना. ब्रांडी सबसे ज़्यादा लोग पी लेते हैं. एक चीज़ आपने बताई कि ना यू ट्राई टू कोरिलेट विद इलिटरेसी.
यस सर.
क्योंकि मैंने जो पाई चार्ट देखा उसमें सबसे ज़्यादा लोग सेकेंडरी में पड़े हुए थे. उसके बाद जो सेकेंड लार्जर ग्रुप था वो अप टू 12 पड़े हुए थे. तो इलिटरेट हुआ ग्रुप तो बहुत छोटा था. So how could you correlate illiteracy with alcohol abuse?
So that is a correlation that I am not saying that it is like that only, but primarily whatever I observed from the data was this finding.
You were describing the pie chart. You said that the number of large number of people illiterate so that it might be related to that. But illiterate हुआ तो बहुत छोटा. आपकी स्टडी की फाइंडिंग्स क्या है? क्या implications निकलते हैं? क्योंकि अपन ने इसको कोई साइकियाट्रिक डिसऑर्डर के साथ कोरिलेट नहीं किया है. अल्कोहल की क्या स्टडी की बढ़ती है या फिर डिप्रेशन लोग भी रहे हैं, एंजाइटी में हो रहा है या बाइपोलर में हो रहा है. तो इस स्टडी की फाइंडिंग्स क्या है?
So the findings would be कि we are able to understand the pattern of alcohol use.
क्यों पता करना है? सर इवन जो आपकी डेमोग्राफिक प्रोफाइल थी उसमें ये था कि ज़्यादातर जॉइंट फैमिली भी थे, मैरिड थे. तो सबके साथ इंडिया में हाँ जॉइंट फैमिली बहुत रहते हैं. लोग ज़्यादातर मैरिड ही रहते हैं. आप शराब पियो ना पियो वो तो बेटा को रहने वाला है. फाइंडिंग्स क्या निकली मतलब जिससे आपको लगा कि मुझे पेपर करना चाहिए?
तो वैसे एक सजेशन है ये बाकी और कोई रेजिंग करे तो इसमें आपको पर्टिकुलर कोई क्लास या कोई कैटेगरी लेनी चाहिए. ये तो फिर पैन इंडिया स्टडी होनी चाहिए देखा जाए तो पैटर्न अल्कोहल हम देखना चाह रहे हैं तो फिर एक पर्टिकुलर जगह पे क्लस्टर पे क्यों करना चाह रहे हैं. तो इसमें एक पर्टिकुलर जैसे करें कोई क्लास लेते हैं, कोई ऑफिस वर्कर लेते हैं, कोई एक जेंडर स्पेसिफिक लेते हैं, उसमें कोई सब कैटेगरी लेते हैं तो ज़्यादा अच्छे रिजल्ट्स आते हैं आपके जिनको ले अच्छा कर सकते हैं आप.
डॉक्टर सृष्टि शर्मा.
Good morning all my respected dignitaries. I am Dr. Sriti Sharma and my topic is personality traits and craving as predictors of relapse in alcohol-dependent individuals across sectional study. Introduction. Alcohol use disorder is a chronic and relapsing psychiatric condition characterized by compulsive alcohol use, loss of control over drinking, and negative emotional states during abstinence. Despite effective detoxification and rehabilitation programs, maintaining long-term abstinence has been a significant clinical challenge. The rate of relapse for the treatment has been alarmingly high, with studies indicating that approximately 40 to 60% of these individuals relapse within the first year after the treatment completion. Emerging evidence suggests that psychological factors like personality traits and craving intensity play a pivotal role in relapse vulnerability. The 5-factor model of personality, comprising neuroticism, extroversion, openness to experience, agreeableness, and conscientiousness, provides a comprehensive framework to understand stable personality characteristics that will predispose individuals to substance use and relapse. Need for study. While there are numerous studies examining biological and social contributors to relapse in alcohol use, the psychological profile of individuals who relapse, particularly in terms of personality traits and craving, remains underexplored in Indian context. Also, most studies have examined either personality or craving in isolation rather than evaluating how they interact together, and a deeper understanding of these variables could inform personalized intervention strategies. This study aims to bridge this gap by examining the association between 5 personality traits and craving intensity among individuals who have recently relapsed following a period of abstinence. Aim to examine the relationship between personality traits, craving, in relapsed individuals with alcohol dependence syndrome. Objectives. Our first objective was to assess the personality profiles of relapsed individuals with alcohol dependence syndrome, to measure the intensity of alcohol craving, to examine the association of the different specific personality traits and alcohol craving, to evaluate the extent to which the personality and craving predict relapse among the alcohol dependent individuals. The study design, it was a cross-sectional study conducted at Mahatma Gandhi Medical College and Hospital, Jaipur. It was a 3-month duration, and I took a sample size of 100 male patients diagnosed with alcohol use disorder who has relapsed in the past few months. Due approval was taken from the Institutional Ethics Committee. Inclusion criteria: the patients were between the ages of 18 to 60 years, diagnosed with alcohol dependence syndrome according to DSM-5, with at least one period of abstinence greater than 1 month. The relapse must have occurred in the past 1 to 3 months and was recent. The exclusion criteria were participants not giving informed written consent, patients having severe psychiatric comorbidity or schizophrenia or with severe cognitive impairment, polysubstance use, excluding nicotine use. Tools used in the study: we made a semi-structured pro forma with social, demographic, and key clinical variables to assess the alcohol use history. Personality traits were assessed using IPIT Neo 60 shorter version, which assesses the big 5 domains: neuroticism, extroversion, openness to experience, agreeableness, and conscientiousness, scored as percentile ranks or raw scores, and craving was assessed using Penn alcohol craving scale. It assesses the intensity, duration, control over their substance taking behavior, duration of craving also. Both the scales were freely available. Statistical analysis data collected was entered in Microsoft Excel and analyzed using SPSS software. Descriptive statistics like demographic and clinical variables were assessed. Inferential statistics, Pearson correlation, t-test, and regression analysis were used. And the first table that we have is of the anthropometric profile. The total number of participants was 100 and the average abstinence period was 2.4 months. The average PACS score came out to be 22.4, which indicates high craving. The personality trait assessment showed high neuroticism. The mean score was 38.9 and low conscientiousness, 26.8. Extroversion, agreeableness, and openness showed moderate scores. This is a graph showing the distribution of craving levels, clearly indicating higher craving. Association of personality traits with craving. We used Pearson correlation tests, and neuroticism positively correlated with craving. The positive correlation shows that higher the neuroticism, higher the chance of craving and hence relapse. And if conscientiousness is low, it increases the chance of relapse because there's a higher craving in these patients. No significant correlation was seen with extraversion, agreeableness, or openness. Conclusion of the study: higher levels of neuroticism and lower levels of conscientiousness were found to be significantly associated with heightened craving and increased risk of earlier relapse among individuals with alcohol dependence. These findings suggest that specific personality traits play a pivotal role in influencing craving, hence relapse vulnerability. We could recognize these traits as psychological risk markers and hence open avenues for developing tailored and personality-informed interventions. Integrated personality assessments can also help in routine clinical evaluations in aiding more effective and individualized relapse prevention strategies, ultimately enhancing long-term treatment in outcomes in alcohol use disorders.
Paper is open to ask the questions.
It's a very nice study, basically trying to figure out if personality and helps in shaping out your relapse or not. How do you define the relapse in this particular case if it's not mentioned perhaps? Because the duration of your study was only 3 months. Somebody who is alcohol dependent, and if we start drinking or once or twice or thrice in a week, but not at his previous levels, do we call it as relapse? Number one. Number two, when personality factors comes in exploring the determinants and predictors of the relapse, does it make a sense to quantify the study into quantitative analysis or qualitative analysis? Number two. Number three, humility and honesty are most commonly required when you are trying to figure out the biological concurrent factors for understanding if you are truly trying to explore the reasons behind the relapse. And unfortunately, this honesty and humility is missing in five-factor model. What is the alternative model to replace the proper domains of this particular one? Have you heard of hexagon model?
Sir, I would like to do the topic and I will think about including it in the
But apparently your study is excellent in, putting up another step in neurobiological understanding in the field of addictive psychiatry. Congratulations.
Thank you. Heminder Singh. Dr. Heminder Singh.
Well, good morning everyone. So the topic for my presentation of this paper is perception about mental illness among medical students. It's a cross-sectional study comparing students with and without exposure to psychiatric clinical postings. Background. Mental illness is a growing public health issue. Perception of mental illness among medical students impacts future care delivery. Exposure to psychiatry may influence these perceptions. Rationale. Medical students' attitudes shape mental health care. Psychiatry postings could reduce stigma and improve attitudes. This study explores this hypothesis objectively. Aims and objectives. Aim. To study and compare OMI scores. OMI is opinion about mental illness. OMI scores between students with and without psychiatric clinical postings. So the objectives are to assess perception about mental illness using the OMI scale, and to compare OMI scores between students with and without psychiatric clinical postings. Methodology. Design is cross-sectional comparative study. Participants are MBBS students with group number 2 and without group number 1. So basically there are two groups. The ones who have attended their psychiatric clinical posting and the other ones who have not. And the tool is OMI, that is opinions about mental illness scale. The sample size is 249. Analysis would be descriptive and inferential statistics. OMI scales. So it has domains. There are 5 domains, namely, number 1, authoritarianism. Second, benevolence. Third, mental hygiene ideology. Fourth, social restrictiveness. And fifth, interpersonal etiology. Participants demographics. So total participants were 249. Group 1, it consists of around 174 students without psychiatric posting. Those who have not attended psychiatric clinical postings. And group number 2, 75 students with psychiatric postings. Those who have attended psychiatric clinical postings. And they are matched for age, gender and academic year. Academic year was the students from the batch of 2019 and 2020. They actually, right now they are undergoing their internship. So the results were mean OMI scores. So for the first domain, authoritarianism, the group 1, which had no exposure, so they had around 5.2. 5.2, that is positive standard deviation, and the group 2, it has around 4.8 mean standard deviation. So mean difference was 6.97 positive and the p-value was less than 0.01. And similarly, benevolence, it has around 6.1 for non-exposure groups, and for the exposure group it had around 5.3. So the mean difference was positive 6.43. The p-value was again 0.01. Same as for mental hygiene ideology, the mean difference was 4.16. P-value was less than 0.01. Social restrictiveness, mean difference was 4.69 positive and 0.01 was the p-value. And in the personal etiology, the mean difference was around 3.24. And the p-value was again 0.01. So the total OMI score for the exposed group was 159 comparative to the non-exposed group, which was around 185. The mean difference was around 25.49. And p-value was significant and it was less than 0.05. So the results, statistical significance. Mean scores for 5 OMI dimensions and total scores as of presented in table number 1. So the group 2 exhibited significantly higher mean scores across all dimensions. That was p-value less than 0.05. That was significant and assumed based on consistent differences. The largest differences were in authoritarianism, that was positive 6.97, and benevolence positive 6.43, followed by social restrictiveness positive 4.69, with mental hygiene ideology positive 4.16, and interpersonal etiology positive 3.24. The total score difference was positive 25.49 and was also significant. So all differences were statistically significant with p-value less than 0.05, showing improved perceptions in the exposed group. This is the OMI score comparison chart. Now the interpretation. Students exposed to psychiatry showed more positive attitudes. Key improvements in benevolence, reduced authoritarianism, and it indicates the role of clinical exposure in changing perception. Discussion supports previous literature showing education reduces stigma, reinforces the need for psychiatric training in undergraduate curriculum, and it suggests experience-based learning is impactful. Limitations for cross-sectional study, so it cannot establish causality, single-center study, so it limits generalizability, and self-reported data may have bias. So the conclusion, psychiatric clinical postings improve perception of mental illness. Training is essential for stigma reduction and empathetic care. Further multi-cycle studies are also recommended.
Now, study is open to ask the question. In your study, you have not mentioned the ethical approval.
Ethical approval, yeah, I got the ethical approval. I actually forgot to mention it.
What was the sampling technique of your study?
Sampling technique. So what we did was, as I mentioned earlier also, we had two groups. Okay, so the medical student were the group actually.
What was the sampling technique?
Technique is
और कोई सवाल पूछना? You want to ask something?
I think from creating the impact of realization and improving the perception, your study makes a real sense. But making the study pre and post exposure to psychiatry versus those who have not attended the psychiatry, pre and post, somebody who were not posted in psychiatry, you evaluate them first, then you post them in psychiatry, you evaluate them later. This difference will actually help in realizing the concurrent validity of what you are going to change after an intervention. What you did is, you have chosen two different populations where somebody were not posted and somebody who were posted. So the perceptions would not be able to make the clear clarity of a group of people who are completely different. So how do you differentiate these two subgroups in statistical methods? So where the sampling techniques will make more sense as sir has asked.
So basically we actually had a questionnaire of around some 56-57 questions. And those questionnaires, they were divided into those domains actually, those 5 domains were there, authoritarianism and benevolence and all. So according to those questions only, we got to know about their perception, what their thinking was, does they have any reduction in stigma regarding this mental illness and all. So this was
आपने पोस्टिंग का क्या फ्रेम लिया? 1 दिन अटेंड करी, 4 दिन अटेंड करी, देखिए
मिनिमम 75% अटेंडेंस थी।
वही तो क्या अटेंडेंस देखी ना, अटेंडेंस कैसे होती है उन्हें पता है ना, तो अटेंडेंस का बेसिस दिया, अटेंडेंस तो बिना है कि होती है बच्चों की।
नहीं सर,
जब हम कोई रिसर्च करते हैं तो हमें कंपाउंडिंग फैक्टर हटाने होते हैं ना कोई।
सर बेसिकली जो मेरे डिपार्टमेंट में एज आई एम फ्रॉम साइकियाट्री सो आई गॉट टू नो हु ऑल आर कमिंग देयर, जो वहाँ पर आए, उन्होंने अटेंड की पोस्टिंग अटेंड करने के दौरान भी उनकी स्टडीज़ भी होती हैं, वो लोग ओपीडीज में भी बैठते हैं, उसके बाद में भी उनसे बात की।
मतलब मिनिमम आवर्स जो हैं वो आपने तय किए कि कितने आवर्स की पोस्टिंग उसने अटेंड कर ली, वार्ड का एक्सपोजर हो गया, इंडोर का एक्सपोजर हो गया, सब
एग्जैक्टली जी।
थैंक यू। नेक्स्ट डॉक्टर निहारिका।
Good morning everyone. Today I am presenting my paper on depression and anxiety following acute myocardial infarction and their correlation with quality of life, a cross-sectional study under guidance of Dr. Paramjit Singh sir, Dr. V.B. Agrawal sir and Dr. Sundar sir. Introduction. Acute myocardial infarction remains a major cause of morbidity and mortality globally. Despite medical advances, the post-AMI period is often marked by psychological distress, particularly depression and anxiety, which can significantly hinder recovery and quality of life. Studies reveal that such psychological disorder may persist for months or even years after the cardiac event, adversely affecting emotional well-being, adherence to treatment, the risk of recurrent events and mortality rates. In India, limited research has addressed this correlation. Most existing studies are based on Western population where healthcare infrastructure, socioeconomic status and cultural perception of mental health significantly differed from those in developing countries. Mental health remains under-assessed in Indian routine cardiac care due to stigma and limited access to psychiatric services. Additionally, few studies have examined the direct impact of depression and anxiety on QL in a structured manner using standardized tools. The objectives of the study were to determine the levels of depression, anxiety and QL among post-MI patients and to examine the correlation between psychological distress and quality of life. Methodology. This is a cross-sectional observational study conducted at Department of Cardiology at SMS Hospital. The duration of study was from December 2024 to February 2025. Ethical clearance was obtained from the Institutional Ethics Committee. The participants included in this study were patients visiting cardiology outpatient department aged above 18 years who had completed the first 3 months following AMI. Selection criteria for patients, inclusion criteria. Patient aged between 30 to 75 years who had completed the first 3 months following AMI were included in this study. This time lag of 3 months was taken when the immediate psychological effect of the event was seen as a reaction to the stress suffering acute MI. Additionally, QL reaches a steady level by minimum of 2 months after the episode of MI. Patients giving informed consent and demonstrate the ability to understand and respond to the study questionnaires were included, and individuals fluent in Hindi or English language. Exclusion criteria were patients with a prior history of major psychiatric disorder, patients with neurodegenerative diseases, substance abuse disorder, terminal illnesses, or those who require intensive care management. Sample size. Assuming a confidence interval of 95% and study power of 80% and an expected correlation coefficient of 0.35 based on prior research, the required sample size was calculated to be 70. Total of 71 patients diagnosed with AMI were included in this study. Assessment tools. There were 3 assessment tools used in this study. First was cardiac depression scale, which is a 26-item scale, total score ranging from 26 to 182. Which score between 90 to 100 indicates mild to moderate depression and score above 100 indicates severe depression. For assessment of anxiety subscale of hospital anxiety and depression scale was used, which is a 7-item scale. And to assess the quality of life, WHO brief QOL Hindi version was used. Data collection and analysis, Pearson correlation coefficient was applied to examine the relationship between anxiety, depression and QOL score. Multiple linear regression analysis was conducted to determine the predictive value of psychological distress on QOL. Data analysis was conducted using SPSS version 23.00. Results. The table 1 describes the socio-demographic profile of the participants. From this table, we can interpret that most of the patients were male who were illiterate. Most of the patients were belonging to rural background and all patients lacked the family history of AMI. Table 2 describes the descriptive statistics of depression, anxiety and QOL scores. In table 3, we can see that out of 71 patients, 45.1% patients were having severe depression, while 47.9% patients were having severe anxiety. 12.7% patients were having mild to moderate levels of depression and 14.1% patients were having mild to moderate level of anxiety. Fourth table denotes the correlation of depression and anxiety scores with QOL domains. Depression scores were negatively correlated with all 4 QOL domains, while anxiety scores were also negatively correlated with all 4 domains. With maximum correlation was found between psychological QOL and social QOL. Table 5th is comparison of depression, anxiety and QOL across demographics. Significant difference was found between environmental QOL and marital status, indicating that participants who were widow or single were having lower quality of life. Significant differences were also found between physical, social and environmental QOL and educational level, indicating that higher education leads to better quality of life. Significant difference was also found between environmental QOL and family type, indicating that patients belonging to joint family were having good outcomes or good quality of life. All models were statistically significant, reinforcing the reliability of these findings. Conclusion. This study demonstrated that the depression and anxiety are highly prevalent in post-MI patients and significantly impact the quality of life across all domains. Depression exhibited strong negative association with psychological QL and physical QL, while anxiety also significantly affected psychological and social QL. Multiple regression analysis confirmed that both depression and anxiety were significant predictors of QL, with depression having a strong impact. These findings highlight the urgent need for integrated psychological screening and intervention in post-AMI care to improve overall recovery outcomes. Further studies should explore longitudinal pattern of psychological distress and examine the effectiveness of mental health intervention in enhancing QL and cardiac patient. These are the references. Thank you.
Now the study is open to ask. What are the limitations of your study?
Sir, the study was conducted in a single tertiary healthcare center. So, this was the one limitation, and it include patients from mainly Rajasthan state only. So, it can socio-cultural variations were also there.
You have mentioned in your study that this study is like unique because it has not been done or conducted in India or in developing world. My thesis topic was the same, and I conducted this study, and I have published 2 papers on this topic. So I think more than hundreds of papers are available on this topic in Indian literature. Any other questions?
Yeah. I think it makes all the sense to identify the quality of life actually deteriorates once somebody develops heart attacks and then depression, both actually contributing to reducing the quality, right? Understandably. But we know that depression also reduces the quality of life and heart attacks also reduce the quality of life. So if you want to actually subtract between the X factor which explain the covariance of variable 1 versus variable 2, which statistical method is apparently used to identify this difference? So any aware? This actually helped by identifying the effect size. Okay. Number 2 is, what are the major differences between cardiac depression scales and the commonly used depression scales? There are 26 items there, right? So any 5 factors which you can mention on?
Yes, sir. Sir, one of the item included in the CDS scale was that there is a fear of dying in the future. Patient has constant worry that he might die in future. Second was if there are any things which got not completed in his lifetime. Now he had an episode of MR and he is unable to do it in future also. Third was
okay, also there is also a predictor for which we can identify or explore. For example, those who develop myocardial infarction, can you identify whom are you likely to develop these depression over a period of time? So any biological test are you aware of to identify? It's called serum albumin levels. Okay. Thank you. This study makes lots of sense. Please appreciate it. And you can get in touch with sir to figure out where it could be improved. Thank you.
Production. Dissociation is interpreted as an unconscious defense mechanism. It can be described as a disturbance in personal identity, memory, perception, and motor behavior and consciousness. It is thought to be a defense mechanism against profuse fear, pain, or helplessness. Aims and objectives: to assess the dissociative experience and type of stressful life events, and also to correlate the events with dissociative disorders. Methodology and statistical analysis. Study type: cross-sectional observational study. 80 patients between the age group of 10 to 50 years. Diagnosis according to ICD-10. Statistical analysis by SPSS version 20. Inclusion criteria: age between 10 to 50 years. Both male and female patients were selected. ICD-10 criteria for diagnosis of dissociative disorder, and those will
exclusion criteria, history of significant medical and gynecological illness, neurological disorders, mental retardation, and current or past major psychiatric disorder, comorbid substance use except nicotine and caffeine. Baseline assessment is specially designed to perform used with identification data sheet and social demographic data sheet. ICD-10 diagnostic criteria for dissociative disorder, dissociative experience scale, 28 item self-reward questionnaire. Scoring from 0 to 100, presumptive stressful life event scale, 51 item scale. Procedure, approval for this study taken from ethical committee. Patient diagnosed as a case of dissociative disorder as per ICD-10, willing to give informed written consent, selected by pervasive sampling method, social demographic and clinical data collected, both scales applied, and appropriate statistical test applied to analyze data. Results. In our study, 80 patients with disorder included. Social demographic profile of the patient are as follows. Mean age was 25.21 plus minus 9.1. Majority of people diagnosed with dissociative disorders were female, 74%. Subjects were from both urban and rural areas equally. Lowest age of patient was 11 years. Maximum was 50 years. Mean age 25.21. 23% of the patients were diagnosed with medical comorbidity that may have a confounding effect. 80% had some psychiatric comorbidity. Percentage of married individual was 40%. 97% of patients were living with their families. That is cause for emotional gains. 42% of our sample population had taken alternative forms of treatment from faith healers. Patients with the diagnosis of type 44.7 mixed dissociative disorder were 50%, which was the highest number in the sample, and 21% presented with dissociative convulsion. All the patients were independently examined and all had different value of PSC scores, with the minimum score 3.5 and maximum of 56 and a mean of 12.05. From this we can conclude that PSC score does not have significance across the types of dissociative disorder. A patient with any amount of PSC score can present any type of dissociative disorder. The distribution of PSC score was same across categories of gender in our study. P-value is 0.357. That's no significance between genders. In our study, all the patients were suffering from dissociative disorder, and the average number of events occurring last in 1 year for our sample was 3.84 plus minus 1.75, which is significantly higher than average for normal Indian population. The mean undesirable events were 2.84 plus minus 1.19, which was also higher than normal average. The high frequency of stressful nature event over a short span of time may have a collective effect on producing illness equivalent to that produced by quantitatively more stressful event over a long period of time. The box and plot showing the distribution of PSLAC scores was same across categories of dissociative subtypes. The stressful life event, particularly the presence of higher prevalence of undesirable events in past 1 year, respiratory dissociative phenomena, or make a person prone to develop dissociation due to impaired coping in face of intolerable stress. There was no statistical significance across the gender. Limitation, the study design, cross-sectional design. A lack of prospective design failed to pick up any changes during the course of treatment.
Now this study is open to ask questions.
आपकी कंक्लूजन से पहले डिस्कशन की स्लाइड एक चीज नहीं
प्राइमरी और सेकेंडरी आउटकम्स क्या है आपके स्टडी के?
सर, जो 2 स्केल अप्लाई किए हैं तो उनसे कोई जो डिसोशियल डिसऑर्डर के सब टाइप होते हैं उससे कोई कोरिलेशन मिला नहीं, क्योंकि स्टडी इनसिग्निफिकेंट है उसमें। और
आपने क्या पाया, प्राइमरी आपने क्या पाया और सेकेंडरी आपने क्या पाया?
मतलब सर इसमें असेस ही कर रहे हैं स्ट्रेसफुल इवेंट कितना 1 ईयर में जितनी इवेंट्स है वो कितना प्रेसिडेंट कर रही है डिसोशियल डिसऑर्डर।
सर वही पूछ रहा था, लाइफ स्ट्रेस पे लगाया ना आपने, उसमें लेवल्स होते हैं स्ट्रेस के, क्या आपने उसमें कोई कट ऑफ आइडेंटिफाई किया जहाँ पे इसके बाद डिसोसिएशन ऑन हो जाता है? इतना तो पता किया होगा आपने।
सर 51 इवेंट्स होती हैं और उसमें मीन स्ट्रेस स्कोर आता है। तो 0 to 40 तक तो कोई स्ट्रेस नहीं मानता, 41 to 200 में मॉडरेट लेवल का स्ट्रेस और 200 सब सीवियर स्ट्रेस। हाँ, मॉडरेट में कंसिडर करते हैं।
मॉडरेट में होता है, उसमें क्या प्रेडिक्टिव फैक्टर्स होते हैं? डिसोसिएटिव डिफरेंस नॉर्मल होता है या एबनॉर्मल होता है?
सर अनकॉन्शियस डिफरेंस मैकेनिज्म है।
थैंक यू।
Thank you, Dr. Ravi. Now we conclude the session of pre-paper presentation. Over to organizers.
Thank you to all the participants, and a very special thanks to our judges of both the paper and the poster presentations for sharing your expertise and giving such insightful feedback. To express our gratitude, we would like to felicitate our dignitaries, and for the same, I would like to invite Dr. Jazair Ali sir to kindly come forward and felicitate Dr. Vinod Dalia sir. I guess he's not here around, so I would like to invite Dr. Murlidharan ma'am to kindly felicitate Dr. Vinod Dalia sir. I request Manju ma'am to kindly stay back and felicitate Dr. Jitendra sir as well. Next, I would like to invite Dr. Murlidharan sir to kindly come up and felicitate Dr. Jain sir. Next, I would like to invite Dr. Sunil Sharma sir to kindly come up and take a token of gratitude. Next, I would like to invite Dr. Parth Meena sir to kindly. We have a representation on behalf of Dr. I would like to invite Dr. Jitendra sir to kindly felicitate Dr. Murlidharan sir. Professor of Psychiatry and Medical Superintendent at NIMHANS, Bangalore. Dr. Kesavan is a highly respected academician and clinician with an exceptional track record in psychiatric research, education and healthcare leadership. He completed his MBBS from Bangalore Medical College and went on to earn his MD in Psychiatry from NIMHANS. Furthermore, enhancing his expertise, he also holds an MBA in Hospital Administration. A faculty member at NIMHANS since 2007, Dr. Kesavan has played a pivotal role in both academic and administrative spheres. He has served as chairperson of psychotherapy program at NIMHANS and held a visiting professorship at Mood Disorders Center of Excellence in Vancouver, Canada. Dr. Kesavan currently serves as president of the Neuromodulation Society of India and co-chairperson of the IPS Neuromodulation Society Division. He is also a member of the Ministry of Health and Family Welfare's Committee for Innovations in Patient Care Services, Government of India. His research and contributions are remarkable, with over 160 peer-reviewed publications and leadership in more than 10 national and international collaborative projects focused on bipolar disorders and brain stimulation, 10 plus research projects, collaboration with NIMH, UBC, Daikin University, Broad University, DST, to name a few. He has also been recognized with numerous prestigious awards, including Asian Young Psychiatric Award by Asian Federation of Psychiatric Association, WFSBP Young Investigator Award by World Federation Societies for Biological Psychiatry, Paris, France, RSA Young Investigator Award by Research Society on Alcoholism, Washington, DC, USA, Young Investigators Award by ICMR and DST, Government of India, Samuel Gershon Award by ISBD 2017 and 2020, and Professor Raghuram Distinguished Young Teacher Award of IPS Karnataka Chapter 2021. Please join me in welcoming Dr. Kesavan, a distinguished teacher, researcher, and a thought leader in psychiatry. I would like to request the audience if they can go and grab a tea and a snack for 10 minutes so that we can do a little bit of setup for the workshop. I would request to all if you come back within 10 minutes.
I said good afternoon. Thank you. Alright, so it is indeed a great honor for me to be here as a part of last PsychCon 2025. At the outset, let me thank for giving me this opportunity to be here and to talk about the topic that I'm very, very passionate about, transcranial stimulation. So I take this opportunity to thank the organizing committee of PsychCon who did a fantastic job. And it's not easy to get so many people together and organize a conference of this magnitude. So congratulations to all of you and thank you so much for the wonderful job. And of course, my own collaborators from the Department of Psychiatry and the collaborators on the Psychiatry team from KP Ranchi. Okay. Am I audible? Can you hear me? Give me a shout out if you can hear me. Yes. All right, great. So how many of you have actually used the TMS equipment before Asia? I am. More of five. How many of you have read about TMS? How many of you have used the TBCS equipment? Okay, how many of you have prescribed ECP? Raise your hand. So a lot more people have had experience of ECP than with ASF. Why is that? So main thing is the lack of access to equipment. Lack of access to infrastructure that makes it necessary for you to get trained in those areas. Right? How many of you have used GPay? How many of you have used any other online payment app? Raise your hand. Yeah, so basically there's not much difference. If you do it regularly, TMS, TDCS is like your smartphone, it's like your Google Pay. Nobody teaches you how to use them. You just use it and over a period of time you get experience and you become experts in it. So non-invasive brain stimulation is not rocket science. It is something that all of us can do. It is just a matter of having that toy and playing with it for a few weeks and then you will become expert. Okay. So today what we'll try and do is I'll just give you a little bit of theory for about 15-20 minutes and then we'll go to the hands-on workshop. What I would like all of you to do is to touch the machine, is to estimate resting modal threshold and learn how the machine feels and how you can do it. That's the whole purpose of this workshop. So in those few words, I'll get on with this.
So this is the outline of my presentation, a brief about the history of RTMS, a little bit about the classification of non-invasive brain stimulation, basic principles, some common terminology, how to plan RTMS treatment, and some RTMS. Anyone, when was RTMS first, when was the first magnetic stimulation attempted? Any idea? How many months ago, decades ago, centuries ago? Take a guess. So actually, we can trace it back to Michael Faraday, the principle of electromagnetic induction, right? So that is when we first understood that electrical current and magnetic fields are related. But if you actually look at the evolution of TMS, one of the first equipment was by G. Arsenwal in 1896. So it's not very new. In fact, it's older than the ECG machine. In 1896, G. Arsenwal and colleagues actually came up with a kind of magnetic stimulator. And then you have a more robust one that Thomson and team developed in 1910. So in between what happened, we came up with the ECG machine. And ECG became the go-to treatment for psychiatric disorders, and TMS kind of fell behind it. The interest in TMS again came back sometime in 1985 when Anthony Parker and colleagues from the Sheffield University actually came up with this equipment that we know today nowadays, because they tried to use it in neurological disorders, particularly in movement disorders. And since then, we have a lot of equipment that has been developed specifically for use in psychiatric and neurological disorders. So you have the FDA-approved machines since 2009 for the treatment of depression, and we have 4 or 5 manufacturers now who are authorized to make TMS machines for use in psychiatric practice. So we've come a long way from 1896, when the first equipment was used, to what is currently available now. So this is the evolution of the TMS machine again. So you had, in terms of the ability to deliver pulses, you had the single pulse TMS machine that Parker and colleagues started in 1885. RTMS came up in 1887. That was only single pulse TMS to use to stimulate the motor cortex. RTMS in humans, so virtual lesions were identified in 1991. So initial trials of RTMS in depression happened in 95-96. In 2007, we had the phase 3 RCT in depression, which resulted in the FDA approval in 2008 for the use of high frequency RTMS in depression. And then you have a whole lot of other things that have happened. So somewhere in between here, I think in 2002 is when I gave the first TMS myself, and in 2004 to 2005, I did my MD thesis on investigating TMS. So my interest with TMS has almost been there for the last 23 years. And believe me, it is one of those rewarding things that you can do as a second. Again, it's basically the same thing that's been represented here. So classification of non-invasive brain stimulation. If you look at brain stimulation, we can divide it into those treatments that produce convulsions and those that don't. And the one that produces convulsion, we know the most popular one is ECT. All of us have used ECT. It is one of the most dramatic and life-saving treatments in the field of medicine, not just in the field of psychiatry, in the field of medicine. I don't think any treatment has saved as many lives as ECT and psychiatry. So that's the most effective, so you know where my loyalty is lying. Apart from that, there are a couple of other treatments which also produce lesions. And of course, you have the transcranial magnetic stimulation, the TDCS, EACS. So these are all the non-convulsive treatments that are now available, where the treatment does not produce specific convulsions but does bring about clinical stimulation. So basic principles of RTMS. So it is Michael Faraday's principle that when there is a time-varying electrical field, it produces a time-varying magnetic field in a direction which is perpendicular to the direction of the electron. And that in turn induces an electrical field in a conducting substance which is in the opposite direction to that one. Right? So transcranial magnetic stimulation basically uses the principle of electromagnetic radiation. Very simple, we can demonstrate it with a point. So it has different components. So you have the coil, the figure of 8 coil. The figure of 8 coil, then you have the capacitor. So this is the diagrammatic representation of the TMS unit that we see. So you have the capacitors, and then you have the stimulating coil, and there is a switch. So every time you press the switch, a time varying electrical field is generated, and that generates the magnetic field, which is what you will apply to the scan. So there are different units. These are the requirements for the PMS equipment which has been put out by the Indian Psychiatric Society a couple of years back. So I think this is what is expected to be there in any center which wants to give. So again the same thing. So these are the principles of electromagnetic induction. And like I said, so this is the PMS coil. You have the electricity which is going in this direction, in this coil, and that induces a magnetic field which is perpendicular to the direction of the electricity. And that induces small currents into superficial layers of the brain, which when summated results in an electrical impulse which runs in a direction which is opposite to that one, and that results in the propagation of an action. So basically the same thing again and again. The important for us to remember is that TNS actually stimulates only the superficial layers of the body. So we know that there are 5 layers in the gray matter, so probably the layer root of the pyramidal cells is what the TNS pulse will penetrate. So the depth is about 2 millimeters. So once it goes past the scan, it just stimulates the superficial 3 or 4 layers of the cerebral pulse. So what are the things that determine the magnetic field? So I'll again explain to you when we do the hands-on. So it basically is to do with the coil geometry and orientation, the rate of change of currents and the distance between the coil and the brain. And the individual related include the site of the cortex, the orientation of the neurons, and the age of the cortex. So what is the strength of the magnetic field will be determined some by the machine related field, okay, and some by the individual related. So if you look at machine related, you can see that the determinants of the induced magnetic field to a great extent is by the degree to which the magnetic field is concentrated in the vessel, and the depth of penetration is about 2 centimeters, and the circular area of penetration, so it's like a cone. So the circular area is about 3 centimeters square, and the depth of penetration is 2 centimeters. So depending on the kind of coil, you will get more concentration of the magnetic field. And then this is the location. So if you have to decide orientation of the coil, so if you look at the orientation of the coil, different protocols will tell you that the coil needs to be oriented in a particular way. More often than not, we have the 45 degrees orientation that we use for stimulating the motor cortex and for the left or lateral prefrontal cortex. So the way in which the coil is oriented also decides on how the magnetic stimulation is going to influence the particle. The terminology. So there are some terms that all of us, you would read in all papers, all of us should be familiar with. So one is the frequency that is measured in hertz, the number of pulses per second. So that is the rate at which the magnetic field is generated. And then you have the resting motor threshold, which is something that has to be determined in every patient for whom you will administer RPM. So it's like your ECG, where you measure the seizure threshold. Whereas RPMS, you measure the resting motor. So it is that threshold at which almost 50% of the trials produce a motor evoked potential of about 50 watts. Or you can see the pitch in about 5 out of 10 trials of naked eye estimation. So I'll explain that on the machine. Stimulation intensity is a percentage of the RNT. So you will find protocols which say use 80% of RNT or use 100% of RNT. So that is the stimulation intensity. Now pulses per trace. So that is frequency to duration. So let's say you have 10 Hz frequency. So that is 10 pulses per second. If you were to deliver it for 4 seconds, then that becomes 40 pulses per second. So that is what we use in depression protocol. So you have the frequency into duration. So that gives you a train, and each train will have X number of pulses. And X number of trains is the frequency. Okay, so they say that we need to give say 30 trains. Each train will have 10 Hz frequency and for a period of 2 seconds. So frequency into seconds is the pulses per train, and number of trains would be the frequency. So whenever you give a train of frequency, so then you would find that there is a time interval between trains, which is also predetermined, to make sure that you are stimulating them. So that is the intertrain interval. Okay. Yeah, so this is how you use to determine the resting motor threshold. So that's the first thing that you will do. You can either do it with a naked eye estimation, or you can use an electromyography. So when you're using naked eye estimation or electromyography, the preferred muscles are abductor pollicis brevis or the first dorsal interosseous muscle, to which the electrodes can be connected. You can do it with the electrodes and without the electrodes, but if you're using the electrodes, preferably use these two muscles because they are quite superficial and they can be connected. And that is connected to the electromyograph, which will generate the motor evoked potential that helps us determine the resting motor pressure. Again, like I said, it is the 50 microvolt is to be responsive 5 out of 10. Okay. Yeah, so this is what I was talking about. So when you're looking at treatment, you will have number of pulses per second, that is frequency. Low frequency is what is 1 hertz or lesser, 1 pulse per second or lesser is called low frequency, and high frequency is 5 hertz or above. So 5 hertz is 5 pulses per second or above, right? So anything that is low frequency is inhibitory, and anything that is high frequency RPMS is excitatory. So these are two important distinctions that we make. So anything which is low frequency, 1 hertz and below, is inhibitory, and high hertz and above is excitatory. So if you look at most of these stimulation protocols, particularly depression, you will have high frequency, and when you're looking at schizophrenia protocols, you will have inhibitory or low frequency. Yeah, so this is what I was talking to you about earlier. So this is a train. This entire thing is a train. So the frequency of this is probably 20 hertz frequency, and it's given for a period of 2 seconds. So 20 hertz into 2 is 40 pulses. So this entire train has 40 pulses. And this is another train which comes about 28 seconds after the pulse. So that is the train. So all treatment protocols of PMS are programmed like this. So you will get a train of pulses, you get multiple trains of pulses, and in between you have the intertrain interval, during which period there will be no stimulation. Right? And the number of trains will determine what is the total duration of the treatment protocol. There are other types of PMS, single pulse and pair pulse PMS. Again, these are more investigative in nature. And then you have the RPMS, the deep PMS, and the pattern PMS, which is the beta nerve stimulation, which is on treatment protocol. Okay, this is what we will be doing. So I will not go into this detail here. So we will be simulating the motor cortex, and that will induce a corticospinal volume, which will be transmitted to the target muscle, which is what we will be estimating when we do the estimation of resting motor pressure. So single pulse PMS is something that everybody will be using when you're doing PMS. This is paired pulse. This is more investigative. I'll explain to you later in case somebody is interested. And then these are the clinical applications which we already discussed. Low frequency increases particle excitability, and so it is inhibitory in nature. Whereas high frequency increases particle excitability, and it is stimulatory in nature. Likewise with patterned RPMS, where you have intermittent and continuous. Intermittent is stimulatory, whereas continuous interval stimulation is intermittent is excitatory, whereas continuous is inhibitory. So basically it's just the same way that RPMS, low frequency and high frequency RPMS. Okay. So what are the mechanisms of action? Like DCP, we don't really know too many mechanisms of action, but there are 3 or 4 theories which have been postulated. So one is it works on long-term potentiation, depression, like synaptic plasticity. It enhances synaptic plasticity by repeated focal stimulation in the area. It enhances cerebral blood flow. It increases synaptic glucose metabolism. There are a couple of other theories which talk about increasing connectivity. So we now talk about psychiatric disorders and disorders of connectivity in brain circuitry. So it modulates the brain circuitry and thereby helps bring about clinical change over a period of time. Long-term potentiation and depression is also one of the mechanisms by which PDCS is believed to exert. So by enhancing synaptic plasticity or by reducing synaptic plasticity. So yeah, it's the same thing, result is different ways. So how do you plan RPMS treatment? So one, screen for contraindications, look for the area of stimulation, locate the target, decide on the type of pulse to be used, and do all the stimulus parameters that have been documented to be effective in any particular disorder. So what are the contraindications for PMS? Anyone? Quickly, come on. metallic implants. So TMS uses a magnetic field. Where else do you use magnetic field? MRI. So any contraindication for MRI is a contraindication. So as simple as that, right? So contraindications, three for contraindications. There are no absolute contraindications for TMS. There are only relative contraindications. One of the things that you must rule out is history of epilepsy in the past or family history of epilepsy, right? So there's absolute, but can I still put it as a relative? Any metallic hardware in the close vicinity of the body, including cochlear implants. High risk of seizures, family history of seizures. So these are something that you have to ask for because that happens to be the most reported adverse effect of TMS, particularly in individuals who have it. And epilepsy, recent heart disease, implanted straight electrodes from DPS, these are all uncertain risks, but then you should ask for. But always ask for metallic implants and always ask for any risk of seizures. Right? So these are the two things that you must do. Again, the same question. So there's a questionnaire that is available. This is also there in the IPS guidelines for TMS. So you can ask some of these questions so that you can be absolutely sure that your patient does not have any contraindications. So area of stimulation is again based on what is the theoretical rationale that is available and what is the access for stimulation. Now we have to find an area that is very superficial so that you can stimulate. So it varies from disorder to disorder. So dorsolateral prefrontal cortex is probably one of the most very stimulated areas. It has been used in the treatment of depression, nicotine dependence, it has been used for treating OCD in some patients. So this is the area that is most frequently stimulated. Apart from this, the other areas include the supplementary motor area, the superior corticoides, PPJ, or temporoparietal junction for auditory hallucinations with schizophrenia, motor cortex for pain and Parkinson's disease. We have been using the occipital cortex also for stimulation, particularly in neurological disorders. Cerebellum is an area of interest, particularly when we are looking at negative symptoms of schizophrenia. So localization of the target site. So we will be doing anatomical localization today in the workshop. Apart from that, there is the EEG 1020 system which is usually used as a guide and can be done without any additional equipment. And it can be done manually, so but it may not be as accurate. The more accurate estimation is usually done with these navigation techniques. So neuronavigation where MRI is used to guide the site of stimulation. So that way we can be sure that we're stimulating the same site every day. Whereas with the anatomical landmark estimation, the chances of mistakes are there, but then that is something that you have to take. It's more practical. Yeah. So these are some of the common areas of stimulation. Like I said, F3 corresponds to the dorsolateral prefrontal cortex. Orbitofrontal cortex is the FP1. The supplementary motor area comes somewhere between F7 and C7, and temporoparietal junction comes somewhere between C7 and. So the accessibility of the cortical areas and the theoretical rationale determines which area of the brain you will be stimulating as a part of your TMS program. So what are the types of coils that we know? So these are the many coils that are available. So more often than not, it's a quest for depth. We want to go as deep as possible. We know that TMS can only stimulate the top superficial edges of the cortex. So the coils have been evolving over the years. So initially there was a circular coil, which is still used mainly in children. The figure of 8 coil is what we use extensively. The diameter of this coil can be about 7 centimeters or 8 centimeters. It varies from manufacturer to manufacturer. But then that is the most commonly used coil. The double pole coil is something that is used when you want more deeper stimulation, either on the cortex or on the cerebellum. So we have used this for stimulating the cerebellar awareness and negative symptoms of stimulation. So this is another proprietary item that has come up. This is for deep brain stimulation. Where you have the H coils, helmet-shaped coils. So you have different coils for different disorders. H1 for depression, H7 for OCD, and H4 for nicotine dependence. So these are the newer advances in terms of coils for depth of stimulus parameters. Again, this is a repetition, but it's important to know that. So stimulus strength is strength of the magnetic field, which is the capacity of the machine, usually between 1 to 3 Tesla. Resting motor threshold is what we will estimate in all patients, and the access for stimulation is something that is important. So what are the factors that decide whether the patient will respond to TMS or not? These are the most important things for any clinician. So one is the site of stimulation. make sure that we are stimulating the same site every day. Locate the site accurately as much as possible, stimulate the same site every day. The intensity of stimulation, is it at RNT, is it 80% of RNT, is it 110% of RNT? So these are measures which will determine how good your stimulation is. Coil orientation, very important. Type of coil that you're using, whether it is a dummy bone coil or figure eight coil. Frequency of stimulation, what is the hertz that you're using? I think as per protocol, we have to do it. Illness-related variables are most important from a clinician perspective. Most of the studies that you have will tell you that it has been used in patients with resistant depression or resistant schizophrenia, resistant negative symptoms, or resistant auditory hallucination. So invariably, TMS has been tried in patients with very severe disorder. A lot of times those who are not available even for ECG. So that is another thing that you should keep in mind when you're deciding on which patients to use and what is the timing of your TMS. So these are two important illness-related variables. So again, these are all the various indications and evidence that are available. These are the last couple of slides. It's basically a summary of whatever was there in the previous slide. Major depressive episode is the most common indication. So you can use high frequency RTMS or intermittent beta burst stimulation. If you're using high frequency, 3000 pulses per day is the protocol, and intermittent beta burst 600. So these are the various coils that are available for stimulation. So major depression remains one of the most common indications. Then you have major depression with obsessive compulsive disorder with comorbid anxiety, smoking cessation, I think the various coils that are available and the protocols that are available for stimulation. We will program all this on the internet. Right? Alright, so any questions before we go to the hands-on workshop? Any quick questions? I'll be happy to answer any questions on the equipment itself, but before that, if there are any questions, I can take it up. Looks like an excellent presentation, no doubt. So can we go to the equipment now? Alright, thank you so much for your attention. Very good question, Ravi. So again, epilepsy, like you rightly pointed out, is more likely to occur when you're using suprathreshold stimulation and high frequency stimulation. And since most of our protocols look at high frequency stimulation, it's very important to stay for this contract. Contrast with epilepsy, most of the protocols that are there would be low frequency, inhibitory kind of protocols, which the idea is to bring down the electrical activity and hence. So the thing is, when you're using single pulse and when we don't know what the RNT of a patient is, you will be using slightly higher thresholds for stimulating so that you can estimate the RNT. The chances of the summative effect going on to trigger epilepsy is fairly high. In fact, with the very first TMS pulse that we administered in NIMHANS, the patient had a seizure. The very first pulse with the very new equipment, 2009, the patient had a seizure. And then when we screened, then we got to know that they had not disclosed family history of epilepsy despite us running the checklist. So the risk is there. The thing is, when it happens, it becomes scary for both the patient and the clinician. It's not that it should not be used if there's epilepsy, but then the patient is less likely to give consent if your treatment is going to trigger it. So it's better to screen first.
Sure. In case if some patient has two sequential seizures with EMS, how would you advocate these other treatment policies?
Stop it. So I think when the risks outweigh the benefits, it is not feasible to continue. Thank you. Sir. Absolutely mandatory. Like with all interventional psychiatric procedures, ECG, PMS, yes, written informed consent is a must for all patients, whether investigative or treatment. You have to have it.
Is there any margin you have to these patients
not really.
There is no history of
Not really. In fact, one of the things that happens with resting motor threshold, which is what you have to do for all patients, is that it is a highly influential kind of, as it can be influenced by a whole lot of things. So that is why one of the things that we advise always is to do TMS at the same time or during the same time of the day for the whole treatment course. So RMP can be lower post lunch, can be higher post coffee, can be higher post smoking. So anything that stimulates the brain will raise the resilience, and anything that makes the brain a little sluggish will lower the resilience. So it is highly variable. So likewise, medications can have an impact on the resilience. So it could either raise the RMP, like for example, medication like lorazepam, anything that enhances GABA is likely to raise the threshold, or anything that reduces it is likely to lower the threshold. Likewise, medications may have an impact on the RMP, but unlikely that they may contribute to producing seizures. Which is why one of the things I usually recommend is that do RMP on every day before you put the patient on the medicine, because it varies from week. So what is RMP today may actually be a higher RMP tomorrow. So it's best to do it every day. It takes a little bit of time, but with the practice it's very easy.
So one question from how much used in the proceeding along with SSI and psychotherapy? Is there any single option we can choose after network improvement post-medicine?
Sorry, sir, once more.
Along with SSI, proceeding, psychotherapy, we can choose RTMS along with that treatment.
RTMS can be given with anything. A lot of times it's an augmentation treatment, right? Just like the patient is on a whole lot of medication.
So is there any experience of in this field, like when you recover the patient like 30% complete treatment of the OCD drug free? We include the RTMS.
With RTMS, but with deep TMS, we are having a lot of patients who are responding well. I think that H7 coil is available.
Yes.
So we have a deep TMS equipment with which we have a lot of success. With the traditional RTMS, we didn't have. We tried many things. We tried the supplementary motor area, we tried low frequency to right dorsolateral console, high frequency to left dorsolateral. The traditional RTMS, we didn't find much. But we had a lot of success with TBCS and HTTBCS in treating resistant disease. And a lot of success with the deep TMS, which is now a newer, not really newer, it's been around for 3-4 years in India. But with that, we found a fairly close.
Thank you.
Okay, shall we go to the equipment? So, Aryan, you have to split the group. Every time we use this figure of 8 coil, you can hear the sound. So every time I press this button, I am actually switching on this coil. When I switch on the coil, there is an electrical current that is running in the coil. Right? And that electrical current generates a magnetic field which runs perpendicular to the direction of the current in the coil. Right? And that, so the electrical current runs here, the magnetic field runs perpendicular to the direction of the coil, and that will stimulate the superficial areas of the cortex and create very a small amplitude electrical current which commute together, and that will be transmitted through the cortical spinal tract into the tapping cortex. Okay, so just put your hand here. So when you start out the TMS treatments or TMS whatever you do, you have to make sure that the patient comes prepared. Just like the so no hair or no oil on the scalp. Don't shave the head, but yeah, no oil on the scalp. Ask them to wash so that it does not increase the resistance that the magnetic field will have. And then you have to take it in concept. So one of the things that you have to tell the patient is that when I stimulate you, you're going to experience a twitch in the muscle. So I will be stimulating the peripheral nerves here, but a whole lot of muscles are being stimulated. You can demonstrate the same thing to the patient. With your permission. Can you feel the twitch? So the same twitch will happen when I stimulate your cortex. right? So that is what we tell them, that this is how you put it. Instead the definitive, I'm going to be putting it on your scan. Now I will show you a very crude way of determining the motor cortex for the abductor polyp. Are you comfortable? Can I stimulate your head? Right? So I just set the output a little high so that I can take an approximate idea of where the ultrasound is. You can move the coil around. I was laughing the same way when I first put it. It's perfectly fine. I'll talk to them. So we have to now decide the location of the motor. So how are we going to do that? PG 1020 system. Who is familiar with the 1020 system? 10, 20, 20, 20, 30, 10. Right? If you measure the so the vertex is actually the midway between these on it. Right? So why don't one of you come in then? Come. I'll help you. Both of you come. You carry it. The other is still. ठीक है. Okay. Measure from this one. That is not part of it. That's a removal here. So you divide it into 5. 4, 8, 8. So 4 plus 8 plus 8 is 20. So that will be your approximately 15 seconds. Sorry, I'm not. Don't mind. It's too late to ask this question. So I just marked it for it. It's better to part the hair and mark it. Okay, so that is your. And you have to go 5 centimeters back. Let's see if we can find the mark. Find it first. Take it. Take it. And you find the mark which I marked. So from here, we measure 5 centimeters back. That is the location of the one of the motor cortex. Right? So the motor cortex. Remember the motor cortex corresponds to the motor homunculus. You will find that there is a huge representation of the thumb area, motor cortex, right? So that is why we prefer to use the thumb for the first orthotic process, which is fairly well done. Okay. Now let me mark the motor cortex also for you. Okay. 5 centimeters. Very high, so I can start reducing it. Most Indians will have an RLT between 35 and 40. So I'll reduce it a little. Give a 6-second to ensure that the muscle is not at the exact position. So the best way to make it to count in your mind. 1001, 1002, 1003, 1004, 1005. So you have to give that position time instead of between pulses. To prevent stimulation, we need to polarization. Okay, so I just keep reducing it by 2% every time. still getting the pitch on the night adaptive molecule. Still quite long. So I just have to keep reducing the stimulator output till I get percentage. That means only 5 or 6 out of 10 trials. That would be the resting quota. So that is the resting quota. And what is the quota? So that can be recorded in the graph. So now I want, after this, I want all of you to divide our space. And you measure each other and mark it, and then you can start doing it.
सी आप ले सकते हैं, CMC ले सकते हैं
और कुछ इंश्योरेंस भी होता है?
नहीं, इंश्योरेंस हम लोग नहीं करते हैं, बाइक की ट्रैवलिंग के लिए हम लोग इंश्योरेंस
किसी को
जैसे कोरियर करते हैं, कोरियर का जो ट्रांसपोर्टेशन होता है।
सीजर आ गए
सर सीजर एक्चुअली में जब ज़्यादा हम लोग ज़्यादा हम लोग सीजर से ट्रांसफर जैसे हमारा जो है
कहीं भी चालू कर दो किसी भी चालू करके सोयल तेरे भी लगा उसका सबका लगा चेयर लगा दिखाने के लिए tell them to come scan oil any gel any oil scan likely to increase the resistance so that is going to increase the magnetic field so that you will not get the help of allow you to set the percentage output. It will go from 0 to 100. 100 is the maximum stimulator output of any exercise. That is programmed like that. So one of the things that you have to do first when you are to the knee or the midpoint of the small joint is one take the stimulator. So the intersection of these two is the otherwise. So you can use the so I put the patient in a relaxed with the single pulse. I is going to elicit a switch like that's the policy. So I have to move it. Measuring state you can measure this. The midpoint is about 80 meters. Yeah, so that is probably the location of the C cell. So you can actually mark it. Mark it. Put the data. So 18, is it right? Any questions? Last couple of questions if you have, I can take it. Then we can take the workshop to a close. This was more to orient people, create awareness about TMS, and open the mind to the various possibilities that TMS and TBCS have to offer. I didn't talk about TBCS today, but maybe some other day I can do that. Any questions? Any last questions? Okay, then if there are no further questions, I'll bring this to a close. Thank you all so much for your attention.
On behalf of our entire team, I extend a heartfelt gratitude to Dr. Murlidharan Kesavan sir for delivering such an enlightening and engaging workshop on RTMS. Your depth of knowledge and clinical expertise were truly commendable, and we greatly appreciate the clarity with which you explained the complex concepts. What stood out just as much as your technical proficiency was your warm and approachable communication style, which made the session all the more impactful. Thank you once again for taking the time to share your valuable insights with us. We look forward to more such enriching interactions in future. Now I would like to invite General Secretary of IPS Rajasthan Chapter, Dr. Jitendra Jingre sir, to felicitate Dr. Murlidharan sir.
Now proceeding for the valedictory function. So I would like to call upon Dr. Vinod sir, President IPS Rajasthan Chapter. Dr. Pal Singh Meena, Vice President, please come forward. Dr. Manu Sharma, Editor of IPS Rajasthan Chapter. Dr. Sunil Sharma, Organizing Secretary of the conference, and Organizing Chairman. Manju Madam, please come forward. Dr. Aditya, please come. पूरे 1.5 दिन की मिड टर्म कॉन्फ्रेंस कुछ ऐसे बीती कि हमें पता ही नहीं लगा ये समय कैसे खत्म हो गया। मेरे ख्याल से सभी लोगों का ऐसा ही एक अनुभव रहा होगा। मैं सभी से आग्रह करूंगा कि वो प्रिपेयर हो जाएं, उनको कुछ अपने इनपुट देने हुए यहाँ के लिए। तो सबसे पहले मैं प्रेसिडेंट सर से बोलूँगा कि वो कुछ 2 शब्द बोलें कॉन्फ्रेंस के बारे में।
1.5-2 महीना बचा था तो मंजू जी का फोन आया, सर हमारी तैयारी अभी शायद तो थोड़ी सी मन में घबराहट थी। और फिर ये जो पाकिस्तान और इंडिया के वॉर के बीच का जो स्टेज है वो बीच में इतना दिन पहले हडल आ गई, तो पहलगाम वाला हुआ था, उसके बाद लग रहा था कि ऐसा कुछ हुआ। तो जो 1.5 महीना था वो बड़ा सांसद भी था कि डेट पोस्टपोन करें, कैसे करें, और सब आ तो जाए थी गर्मी के अंदर। सब मैंने कहा मैडम बोर्ड रखें, डेट को एक बार फाइनल रखें। मैंने फिर खैर जल्दी से देखा, पर जो उनकी क्वेरीज थी उससे मुझे लग रहा था कि कुछ अरेंजमेंट पे हो सकती है। लेकिन यहाँ आने के बाद मैंने बोला मैडम आपकी किसी तैयारी थी, जैसे होता है ना किसी पेपर की तैयारी बहुत अच्छी होती है, वो भी कहते मेरी तैयारी अच्छी नहीं है कि नजर न लग जाए। तो वो वाला एटीट्यूड लगा मेरे को, ऑल फिट प्रोग्राम लगा। और जिस तरह से लोग, मैंने कल भी बोला था, जिस तरह से लोग आए और जिस आदमी से रुके हैं के ऊपर, वो सब ऑर्गेनाइजिंग टीम और मैडम के निर्देशन में जिस तरह से उन्होंने लोगों को अप्रोच किया और बुलाया है, उस सब का एक कमाल हो।
मैडम मैं तो बहुत ज़्यादा आभारी हूँ आपका कि आपने इतने कम समय में इतनी अच्छी कॉन्फ्रेंस की, और आप सभी का भी आभार क्योंकि भीषण गर्मी में केवल एक एकेडमिक टेस्ट आपको ज्वाइन करने के लिए आप लोग बड़ी संख्या में अलग अलग मेडिकल कॉलेज से बता रहे, अलग अलग फैकल्टी मेम्बर्स और रेजिडेंट्स, और जिस तरह से उन्हें पेपर प्रेजेंट करने और जो पोस्टर्स और क्विज और वो साथ आप देखते बनता था। आई स्पेशली लाइक टू कॉपरेट Madam for choosing such a bold team in the times, the delicate times when scientific temper, logic and all are at stake. ऐसी स्थिति में, ऐसे समय में एक ऐसे संवेदनशील मुद्दे को उठाना और सबके सामने प्रस्तुत करना, ये एक बहुत बड़ा चैलेंज भी था और एक बहुत ज़्यादा एक बोल्ड और रेवोल्यूशनरी स्टेप भी था। तो बहुत बहुत धन्यवाद और साधुवाद की बात है मैडम और उनकी इंटायर टीम। थैंक यू।
I would like to extend congratulations and heartfelt gratitude to Dr. MGUMST, Dr. Murlidharan, and the entire Department of Psychiatry of MG Medical College, and the entire organizing committee, the people who have been part of the stage, in front of the stage, backstage, the student volunteers. Your efforts have truly reflected dedication and great dynamism. I'm sure that this particular conference has been a great success because I think there was a turnout of 150 plus delegates, which speaks to importance of the theme that was chosen, and this also generated great amount of interest in the participants. The scientific sessions, the workshop, the hands-on experience on RTMS. I think it was a very valuable orientation for residents and many of us faculty members as well. So, great once more thanks to Dr. Manju Bhaskar, Dr. Aditya Soni, the entire organizing committee for their hospitality and their warm welcome in nature, and your humbleness and your sense of service to the IPS Rajasthan chapter is truly appreciated, and we look to collaborate with your department in future, and best wishes to all of you. Thank you, ladies and gentlemen.
ऑडियंस में से कोई पीजी रेजिडेंट्स और फैकल्टी अपने विचार प्रस्तुत करना चाहते हैं, सो प्लीज.
So thank you very much for this really wonderful conference. Thanks to the organizers. हर चीज टाइम पे शुरू हुई, हर चीज टाइम पे खत्म हुई. बहुत अच्छी कॉन्फ्रेंस. ये सब चीजें यहाँ वेरी वेल ऑर्गेनाइज थी. थैंक्स टू महात्मा गांधी मेडिकल कॉलेज, स्पेशली मैडम, HOD, पूरी टीम, एग्जीक्यूटिव कमेटी, सब लोग. थैंक्स.
Anyone else? पीजी रेजिडेंट में कोई कुछ अपने विचार रखना चाहेगा? Now I request organizing secretary, Dr. Aditya, to.
Respected dignitaries, esteemed speakers, delegates and participants. As we draw the curtains on second mid-year conference of Indian Psychiatric Society, Rajasthan chapter, Rajasthan Psychon 2025, it is with a deep sense of gratitude and fulfillment that we thank each other, each one of you, for making this event a great success. Special thanks to our patrons. Over the past 2 days, we have witnessed an inspiring exchange of ideas, thought-provoking discussion and meaningful deliberations around our central theme. We extend our heartfelt thanks to our distinguished speakers, panelists, whose expertise, vision elevated every session. Also, we would like to thank sponsors, Indus, Sun Pharma, Microlabs, Torrent Pharmaceuticals, Greenway, Brilliant Medicines, Dentec, Alata, Septadil, Sigmoid, and Neurosoft. I would also like to thank our event team, the Vision Plus team, Ashish Bansulti and Navneet Khandelwal. Thank you once again, and we look forward to welcoming you at future conference. Safe travels and warm welcome.
I request you, Dr. Manju Bhaskar, ma'am, organizing chairman, to share your experience.
Thank you all the delegates. Actually conference को successful बनाने में आप सबका ही सहयोग था कि इतने सब लोग आए यहाँ पे और हमारे साथ रहे, और हम लोगों को भी इतना मौका मिला कि आप लोगों की सेवा कर सके हम लोग अच्छे से. दूसरा ये था कि जो अपनी एग्जीक्यूटिव काउंसिल है, जो IPS राजस्थान चैप्टर, उनका बहुत ज़्यादा सपोर्ट रहा इस कॉन्फ्रेंस को ऑर्गेनाइज करने में. जो भी मैंने किया वो हर चीज़ उनसे पूरी गाइडेंस के साथ किया कि कब कैसे करना है. उन्होंने पूरा सपोर्ट किया. स्पेशली डॉक्टर जितेंद्र जिंगर सर, डॉक्टर गदिया सर, मैंने सबसे पूछा, मतलब कोई भी ऐसा नहीं जिनको मैंने कॉल नहीं किया, और सबसे पूरा सपोर्ट लिया. और जैसे जैसे उन्होंने गाइड किया वैसे कॉन्फ्रेंस ऑर्गेनाइज की. और दूसरी चीज़, जो मेरे डिपार्टमेंट के रेजिडेंट्स हैं उनके लिए क्लैप, क्योंकि रेजिडेंट्स के बिना ये कॉन्फ्रेंस हो ही नहीं सकता. तो डिपार्टमेंट के रेजिडेंट्स हैं, प्लस जो मेरे रेजिडेंट्स यहाँ से पास होके जा चुके हैं बॉम्बे और अहमदाबाद, बट स्टिल वो कॉन्फ्रेंस के लिए यहाँ पर आए सिर्फ मेरी हेल्प करने के लिए इस डिपार्टमेंट की हेल्प करने के लिए थैंक यू। रेजिडेंट्स और मिडईयर फैकल्टी, डॉक्टर गीतिका चोपड़ा, डॉक्टर प्रियम, डॉक्टर शिखा, सीनियर रेजिडेंट्स, डॉक्टर स्नेहा, इन सबके बिना ये कॉन्फ्रेंस मैं नहीं करवा सकती थी। मतलब ये था कि पूरा जब से कॉन्फ्रेंस की डेट फाइनल हुई तब से डे 1 से दे आर विद मी, फुल सपोर्ट। एंड सेकंड विजन प्लस, थैंक यू विजन प्लस, इतने अच्छे से स्मूथली हम लोग ने वेन्यू पे शायद सिर्फ 2 बार विजिट किया और एक दिन कॉन्फ्रेंस के पहले, बट विजन प्लस ने सब कुछ अपने आप पूरा अच्छे से ऑर्गेनाइज किया। थैंक यू विजन प्लस, थैंक यू। थर्ड स्पॉन्सर्स, जो हमारे स्पॉन्सर्स हैं सन फार्मा, इंटास, माइक्रोलैब्स, टोरेंट फार्मा, ब्रेन वेव, अलार्टा and one more, Sigmoid. These are the pharma company who supported us and thank you so much. Thank you so much. Thank you Mahendra sir. सर ने हमेशा मुझे, जब से कॉन्फ्रेंस था हमेशा सर ने मुझे बोला, हमेशा हेल्प ऑफर की। थैंक यू सो मच एंड थैंक यू मुरलीधरन सर, यहाँ पे आने के लिए। सर को एक बार इनवाइट किया एंड देन ही वाज रेडी टू कंडक्ट दिस वर्कशॉप एंड रियली थैंक यू टू ईच एंड
थैंक यू मंजू मैडम। नाउ जैसे सादगी जगावत क्विज कंपटीशन हुआ था, उसका रिजल्ट तो आप लोगों को पता है, बट जो फ्री पेपर कंपटीशन और पोस्टर कंपटीशन हुआ था उसके रिजल्ट्स जो है, तो मैं उसके रिजल्ट्स बताना चाहूँगा। तो फ्री पेपर में जो विनर है वो है डॉक्टर आर्यन कोटिया और फ्री पोस्टर डॉक्टर भुवनेश्वर मीणा from SMS. सर्टिफिकेट आप ऑर्गेनाइजर से कलेक्ट कर लेंगे जिन लोगों ने पेपर और पोस्टर प्रेजेंट किया है, और आप लोगों को सर्टिफिकेट जो विनिंग सर्टिफिकेट है वो राजस्थान की मेन कॉन्फ्रेंस में मिलेगा। कॉन्फ्रेंस की बात करें तो सभी लोगों ने ये एक्सपीरियंस किया है कि जो हॉस्पिटलिटी रही है मैडम की तरफ से और पूरे डिपार्टमेंट की तरफ से, और जो प्रेजेंस रही है वो लाइक एक्स्ट्रा ऑर्डिनरी है, क्योंकि हमने ऐसा कभी मतलब बहुत कम देखने को मिलता है कि जो ऑर्गेनाइज कर रहा है वो इतना इन्वॉल्व है और लाइक पूरी टीम बैठी हुई है Day 1 से लाइक अभी तक। और मैं एक छोटी सी बात बताना चाहता हूँ कि मतलब इन्होंने इतना डिटेल में ध्यान रखा है कि जैसे सेक्रेटरी है IPS राजस्थान चैप्टर की या प्रेसिडेंट है, तो उनको कौन कौन उनके गेस्ट, चीफ गेस्ट कौन आने वाला है, गेस्ट ऑफ ऑनर कौन आने वाला है, तो एक पेपर पे लिख करके दिया कि ये हमारा चीफ गेस्ट है, तो आप अपने भाषण में उनका नाम बोल देना। इतना डिटेलिंग कोई नहीं करता है। तो आप ये समझ लीजिए, आप जैसे रिज्यूम है जो चेयरपर्सन है, तो ऑलरेडी 3-3, 4-4 कॉपी डेस्क पे पड़ी है कि आपका एक आध मिस हो जाए तो दूसरी अवेलेबल है। ये बहुत माइनर चीजें होती हैं, ठीक है, खाना अच्छा बन गया ये तो ठीक है, ये सारी चीजें हो जाएगी, लेकिन ये इन छोटी छोटी चीजों का ध्यान रखना इट्स रियली कमेंडेबल। तो 3 cheers फॉर द टीम महात्मा गांधी।